So, good morning, everybody. Welcome to our Trust Board held in public this morning. And very warm welcome to all members of public who join us at this time. If I could just go through what I think we're probably all very familiar with now. The meeting is live streamed and there will be a recording of the meeting on our YouTube channel. We do have the feature of live subtitles, if you would like to use those. And at the last meeting, I'm pleased to say, it was agreed that members of the public and staff who join the meeting would be given the opportunity to provide feedback on the board meeting. I think some of you will remember we've done this before, many years ago, and we had some really useful feedback. And so we've got slightly more techie ways of doing this now, and our company secretary is going to post a link to the questionnaire into the meeting chat. So we will really welcome your comments on that. And while welcoming people, I'd also like to welcome Richard Kramer, who's joining us as one of our new substantive non-exec directors. And this is your first meeting, Richard, so you're very welcome to be here. And we also have Dr. Michael Rowe, who is a clinical oncologist, who is going to be observing the meeting today as part of his development and helping him to increase his awareness of leadership in our trust and in the NHS. So he will also be very welcome when he joins us. I think we have other people joining us via the public link. Lucy Brown, the maternity and neonatal independent sector advocate for Cornwall, Isles of Scilly and Plymouth, will be attending using the link. So welcome to you, Lucy, and also James Minogue, the Acacium Group, who is going to join via the Teams link. And I'm sorry to just pick out two or three by name, really to welcome everybody, because we do take very seriously that this is a meeting held in public and we really value your attendance. If we could remember to have our mics on mute if we're not speaking. Please, if you're introducing a report, assume the board has read the report and aim for that 2-minute max presentation slot. We'll ask questions once our speakers have finished. We're going to do our best to avoid the use of acronyms, although I think, Alistair, you may be called upon by me to explain some in the Learning from Deaths report. I got tied up reading that, but we do try, and we don't have any fire alarms planned. So if members of the public, please, could raise any questions you'd like to ask on matters we discussed this morning, please do that through the question and answer function, and our company secretary will ask the questions on your behalf at the proper slot in the meeting. We will attempt to conclude by 2:30, but we will have a break during lunch. I don't have any apologies for absence this morning, although I do have a number of people joining on Teams who might normally be here because of other commitments. So, are there any declarations of interest from members of the board? Lots of shaking heads. Nice to see you. Thank you. And could we then come to the minutes of the meeting held on the 7th of March? Are there any matters of material nature that are needing to be changed or raised? I think that is a no. That brings us to the action log. There are very helpful notes. Thank you to those who do the notes on that action log. Are there any questions people would like to ask on the action log? No. So if we agree that we will agree is complete, those proposed complete, and we will monitor the progress of the others. Thank you. That brings me, I think, to our board story, and I'll invite Kim O'Keefe, our chief nurse, to introduce this item. But perhaps before I do, Kim, I would like to welcome Kate Fleming, who's our pain services manager, Jane Thomas, who's a pain specialist nurse, who will both be joining the meeting to take any questions. So thank you, Kim, over to you.
Thank you. Pete, first slide, please. And I see Jane and Kate are with us, so welcome, as Mari has said. So today we're going to take an opportunity to have a look at a patient experience, as we always do at the start of our board. And I'm just waiting for the slide to come up. And today we're looking at Stephen's pain clinic story. And it's really important that we hear from the voices of our patients. And I'd like to thank Steve for helping us understand his journey with us. And we have, as you say, Maury, we've got Kate and Jane then to answer questions. So if we can go to the next slide, please, Pete, and go straight into the video.
Due to a car accident that happened in Australia, in Sydney, in 2003. Lots of surgeries, fusions in my neck and lower spine. And from that, I somehow developed spasms, and they had no way, especially in Australia, they had no way of controlling the spasms. The pain was just like having a permanent slip disc all the time. But the spasms were just a different league of pain. And then we moved over from Australia to here, 2012. From that, the GP said, I think I saw the GP here, got all the usual meds and stuff. That went on for a year or two, and then he said, I think I'll refer you to the pain clinic. They don't make you feel like a patient, they make you feel like a friend, and they really feel your pain and what you're going through, so you don't feel trivialized or anything like that. It's that they're so lovely. About 8 months ago, I was getting to the point where I was going to do something stupid again. I just got tired of living. It was living with pain constantly, living with spasms. I had to, everything I did, there was a consequence for doing that. If I walked up the back garden or something like that, there's a consequence for doing that. Everything had a consequence. And I just didn't want to live like that anymore. So Dr. Gattel suggested the spinal cord stimulator. I was going to be happy if I could get 20% relief. I wasn't expecting to get, and you go through a process with them first of like a psychological thing to make, to see what your expectations are of it. Don't put too much into it, So I was sort of, if I get 20%, I could live with that. I can manage the pain with 20%, da 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 da. And I'm almost pain free. I didn't know I got up after the surgery, went to the toilet, and the nurse said, look at your leg, look at your foot. And I didn't even know I was walking like properly, because I've always walked with a limp for so many years. And I'm kidding. It's like winning the lottery. It was to walk almost normal. Miracle, really. And sitting here now, I've got like 5% pain out of just nothing really. It's life changing. I wouldn't be here now if it wasn't for Dr. Gatterow and his team. They are, I don't know, I would do absolutely anything for this hospital and Dr. Gatterow and his team. Yeah. Thank you so much for saving my life. All of you, from Dr. Gatterow, for the nurses, all the staff, receptionists, everybody. You're amazing, and thank you.
I'm not quite sure what to say to follow that, but Kate and Jane, I don't know if you'd like to add anything to it before we open up, answer questions.
I think like you, we were quite emotional when we saw that video, because it's not every day you get to hear exactly how life-changing something you do is. So I think we were very moved by what he said, but obviously very pleased for him that he had the result that he did.
Thank you. Maury, if I open the floor to questions?
Yeah, thank you, Kim. I feel like you in terms of how could you follow that? It was an amazing presentation, and completely echo the thanks to the team. Wasn't it wonderful that he said they make you feel like a friend, not a patient? And that's incredible, isn't it? So thank you for the work you do and for that presentation. Colleagues, are there questions you might like to raise or comments? Yeah, Robin.
Hi, thank you. I think it's great to see and hear those types of that type of feedback, because it just reminds us that we change people's lives every day in so many different ways. And it's so heartwarming to hear our patients describing our staff as acting like friends. And that's exactly the culture that we're trying to drive across the whole organisation, and see that reinforced is brilliant. But it just grounds us that in everything that we do every day, we have such a big impact on every individual that touches our hospital. So thank you for sharing that with us.
Yeah, thank you, Rob. Kim, you wanted to come back?
Yeah, I think this is a prime example of how pain changes your entire life, not just your physical life and restrictions, but also your mental health. The fact, that Stephen speaks about being driven to do something silly is really sobering, isn't it? And Kate and Jane, I don't know if you want to talk about some of the work that you're doing, that embraces the physical as well as the mental health aspects of pain.
I suppose it's a key part of all of our consultations, and a lot of our referrals come in from elsewhere, GP practices, other clinicians, patients. There's a whole lot of mental health issues. There's not much support out in the community. It's very restricted, and we don't have much to offer patients out in the community either, and a very a small provision within our service. We've got no psychology because we can't recruit into our vacancy. So we have a pain management program with a very small provision of 10-week program. So we just try to embody a culture of friendship with our patients, really, because actually a lot of them do see us as a real support, because GP appointments are restricted as well. So I don't really know what to say, but actually mental health is just integral to our whole management of a patient. We see the whole patient, not just the physical. Yeah, I'd just like to add to that. I think anybody that's lived with pain for any number of years sees how much it changes them as a person. And I think you can see in Stephen there, he was in really quite a dark place for quite a number of years, and has been a patient of ours since 2013. And we've seen him through a long journey up until when he had his spinal cord stimulator put in. So it's not just the stimulator that made the difference, it's his whole journey and how he's managed to work through living with his chronic pain, which has got him to where he's at now. And that's a whole team approach. It's not just Kate, myself and Dr. Gretel. It really is a whole team approach that enables patients to get to that point. I think the other really excellent thing with Stephen as well is that he's now opioid free as well. So when he came to us back in 2013, he was on quite high doses of morphine, and obviously all the side effects and effects of all these drugs are horrible. So actually now, he was, as soon as the implant went in, he literally the next day stopped his opioids. It's not what we would suggest to anybody, but that's the kind of character he is as well. But he has stopped all his opioids. He's on very minimal medications now. So that's, so financially that's a massive saving. So you look at the cost of the stimulator, but actually you outweigh the effect of those drugs as well. So a lot of what we do now, having been, Jane and I have been in this clinic a very long time. So we've gone through the whole time where patients were escalating up analgesia, and now we're working to help patients de-escalate on medications, and we're very much more about the holistic person and trying to get patients off chemicals. So it's that whole mind and body thing as well.
Absolutely speaks to it speaks to my heart listening to what you're saying, and I'll bring Richard in. I just I was thinking about how much of your learning and what you do in your clinics is shared with other teams in the trust? Because often it is the whole person that we are treating, isn't it? So do you share your learning with other people?
Sorry, Jane and I are looking at, we probably don't particularly actually, because we're very much more chronic pain outpatient based. So I've got a whole integrated inpatient nursing team who go out to the wards. And again, they are seeing much more complex patients who are, so again, they are sharing that story of asking patients to reduce their medications. And, you know, if you deal with somebody post-operatively, clearly, yeah, it's a different beast, isn't it? But actually, for patients who come in with acute episodes, we've got a chronic pain background, who are on huge doses. Again, there will be sometimes difficult conversations with patients to ask them to reduce medication. So we are, again, you know, we are much more holistic. So yeah, it is kind of shared out there.
Yeah, and I think our consultants are very much involved with some of the community work with the pain cafes and sort of the sort of spread into the community. So that is part of what they do as well. Yeah.
Thank you. Richard and then Alistair, please.
Yeah, thank you very much, and thank you for the presentation, and thank you to our patient colleague who shared bravely their story with us. Mary's taken a bit of the question from me, really, around how we distribute our way of working and our behavioural approach to pain, because pain is one of the areas, I think, where the cognitive, the somatic and the emotional side of things come really into sharp focus, and addressing all of that in a holistic way is really important. I think I heard you say that we were struggling to recruit psychologists, and I just wondered if there's anything that the board could be doing in support of your team to ensure that we have all of that multi-professional and interprofessional expertise in one place to support you. Is there anything more we could do to help?
Richard?
Yeah, that's a really difficult one, because I don't know if actually getting the people interested in coming to work within psychology within the trust, I think is been tricky for quite some time. I think there's probably, we're looking at ways of working differently. Maybe we can look at more counselling style rather than a clinical psychologist. But yeah, any ideas from the board and how that could happen would be greatly appreciated, because it is a little hole in our service currently.
Just before I bring Alistair in, it occurs to me, just listening to you, so forgive me, but just thinking, how much are you able to use volunteer support?
We don't have any volunteers in the service, and I don't know how we would go about utilising them within the trust environment. I think the pain cafes out in the community, they do use expert patients and volunteers, but we haven't got like that.
Thank you. Alistair.
Yeah, so I just wanted to say thank you to the team and make a couple of points, really. I think spinal cord stimulators are, I guess, still a relatively new treatment for patients with chronic pain, but they don't work for all patients with chronic pain. But when they do, they are life-changing, as we've heard in Stephen's story. And whilst that technology is relatively expensive, if you add up all the medications that's required over years of treatment, if you add up the amount of time that people take off work because of chronic pain, they're undoubtedly a really great part of the armamentarium. And the other thing was just again to say thank you to the staff. That compassion that our staff show for our patients is incredibly important, and I think it's reflected frequently when we have staff and patient feedback that compassion by our staff for our patients often comes out right at the top of the scores. So this is a really good example of that, and thank you again.
Thank you, Alistair. That's really helpful to hear for those of us who don't know. Are there any other thoughts from? Yes, there is one hand up. Is it yours, Paul?
It is, Mary. Thank you. Good morning, everyone. Thank you so much for that story. I just wanted to pick up. Apologies, you can't see me. My camera's not working today. I just wanted to offer you the chance to meet with my lead for recruitment, and then we can look at any options we can do to help you with that. So I'll put you in touch with Jackie Critchley, my lead on recruitment, and we'll meet and see what we can do for you. Thank you.
Yeah, thank you.
Yeah, and I'm sure our service lead would be happy to meet with anybody from the board. She's probably got plans and ideas in her head.
She's got ideas. Yeah.
And I think Kim's put a note there in the chat, so perhaps Kim, I'll bring you in and let you say that.
It's quite fortuitous sometimes having dual roles across RCHT and CFT, which is our mental health trust. So, Paul, I'll get one of my team to link up with Jackie to meet with the team to see what we can collaboratively do across both organisations.
Thank you, Kim.
Hey. So I think if you could please convey the thanks of the board to your team, but also if there is an opportunity to thank Stephen for being brave to share his story, because it is always difficult to tell a story, and we saw his emotion there a little bit while he was telling us. So we've really benefited from listening to him, and I know other members of the public will have benefited. So thank you very much. And as I always say to visitors, you're more than welcome to stay with our public board if you would like to, but you certainly don't have to. And thank you for what you're doing.
Thanks very much.
That brings us then to, I beg your pardon, we should note the story, thank you. Then coming on to my report, I have already welcomed you, Richard, and there's a little bit about you in there. You and I had a conversation last night reminding us not to mix up which organisation you previously served in and are still currently working for. So we'll do our best not to do that, but you genuinely are welcome as a new board member. Other things to note perhaps is just to say thank you to Andy Whitfield, whether he was pressed or whether he volunteered, I'm not sure, but he's agreed to take over the Charitable Funds Committee following the March meeting due to Sarah Newton's conclusion of her tenure. And so I'm really grateful for that. Thank you. And also, if I may say, the Organ Donation Committee, which isn't a large committee of the board, but nevertheless is an important committee because of the work that it does. So thank you for doing that. I think I won't say any more. If people have any questions on my report, very happy to answer them. Richard.
Thank you. I just wanted to note that I was really pleased to see the mention of the Oliver McGowan training because it's really, really important that disabled people are the heart of decision making, and it reinforces the need to have a compassionate care informed by and with disabled people. So I'm very much looking forward to the training later on.
Thank you. Thank you, Richard. Anybody else? No? Okay, in which case, please could you note my report, and we'll come on to Steve's Chief Exec's report, please.
Yeah, thank you, Mary. Just a couple of things I'd like to draw out from the report or add to where items have progressed since papers were published. First one is the operational plan for this current operational year 24-25. RCHT and Cornwall Partnerships NHS Foundation Trust and the Integrated Care Board have all undertaken their board meetings over the course of the last 2 days, and we can update now that all organisations have agreed the finalisation and submission of our 24-25 plan for our system, and all 3 statutory board organisations have supported that plan, which delivers on all of the headline performance requirements that NHS England require, including the intention to deliver a balanced system budget for the system, and for that balanced budget to be achieved in each of the 3 statutory organisations as well. That's a significant step forward. However, it continues to be a very challenged operating environment for all parts of the NHS and for us locally in Cornwall and the Isles of Scilly. So I think we should recognise how challenging this operational year will be for us to achieve those intentions that the 3 boards have now agreed. That's the first thing. Secondly, the board paper refers to the System Improvement and Quality Committee with its first meeting scheduled for Friday this week. All 3 organisational boards have now signed off and authorised the establishment of that System Improvement Quality Committee. So another important step forward for us as a integrated health and care system. The first meeting is scheduled for Friday, and that agenda includes the terms of reference for the committee and a number of reports that will be provided, and we would be expecting to review the effectiveness of that committee after 6 months once we've undertaken the first 3 meetings to identify any learnings and opportunities for that to be further refined and further improved. Then thirdly, not mentioned in the report, but just to update all board colleagues that the Care Quality Commission CQC have arrived this morning to undertake an urgent and emergency care inspection under the single assessment framework. We expect our CQC colleagues to be with us today and possibly tomorrow. And as soon as we have any feedback from CQC colleagues, we can provide that to board members. So CQC colleagues are currently with our emergency department teams, and they'll be talking to staff, patients, and I'm sure going to other parts of Royal Cornwall Hospital over the course of the next 24 to 36 hours. Just segueing in then to urgent and emergency care performance, we continue to be in a challenged operating environment from an urgent and emergency care performance perspective. We see that with our escalation spaces continuing to be used in the emergency department and continuing to be used in boarding spaces in our ward areas. And I know that that level of pressure is being experienced across our hospitals and across the wider health and care system. However, we have seen some significant improvements over the course of the last 4 weeks, particularly in respect of ambulance handover delays and ambulance category 2 response times. I think it'd be too early, Mary, to say that those improvements we would expect then to be sustained and built on going forward. However, those improvements have been significant, and they have enabled, for the whole month of April as an example, a significant improvement in the average ambulance handover time, where ambulances waiting to hand over to emergency department at Royal Cornwall Hospital, and significant improvements in category 2 response times, which are welcome. We are starting to see a reduction in the length of stay in our emergency department, and also starting to see that in our AMU areas as well. So all positive signs that I think reflect a huge amount of work from colleagues right across Royal Cornwall hospitals and across our health and care system. And we need to see those improvements continue so that we can provide improved access going forward. But I would like to acknowledge the huge amount of work from our staff and from our partners across the health and care system to enable and support that. If I move on briefly, the report includes an update on West Cornwall Hospital. And we'll see that we have attached a report that we provided to the Integrated Care Board, providing an update on the progress being made towards the options which could enable a return to 24/7 services at the Urgent Treatment Centre at West Cornwall Hospital. As we've previously briefed boards, the current opening times deliver the full requirements of a National Urgent Treatment Centre specification. However, we are commissioned for those services to be provided 24/7. And as you see in the report, teams are continuing to review options that could enable those opening hours to be extended further. And then we'll see in the report a comment about stroke mortality. We are expecting the publication today of the latest national stroke audit. We do expect that to identify that stroke mortality in some aspects continues to be an outlier in terms of that data set. But of course, there's a huge amount of work underway through our System Stroke Improvement Board and with colleagues across Royal Cornwall hospitals to identify opportunities for further improvements there. And then if I could just finally, I mentioned the work of colleagues across our organisation to improve urgent and emergency care performance. There's a huge amount of work underway right across our organisation. We've seen some great performance around cancer recovery, and that continues. Those positive signs around urgent and emergency care performance. Significant work underway, of course, around elective recovery, and in fact, right across our organisation, colleagues are working exceptionally hard. So I just want to finish by acknowledging that and saying thank you to all of our staff and everybody involved in Royal Cornwall Hospitals who's working so hard to enable those improvements to be progressed. Thank you.
Thank you, Steve. I really endorse that because we know, and we heard in the last item, didn't we, from Stephen, our staff do work under really difficult circumstances and they do it day in, day out. So very, very nice to hear you say that. Thank you for your report. As ever, it's helpful and informative. I think perhaps before inviting questions, I would just like to comment on what you said about the operational financial plan. It has been difficult to achieve what we have achieved, and it's to be celebrated. And yet this is the beginning of a long journey, I think. And I think it's as well, as you've done, to say in public that we do need to continue to work hard to make the best use of our resources. And so that will mean some changes. And clearly nobody likes change, but I think as we go through this year with some difficult decisions, we will really value the support and responses from our communities as we try to get it right for them. So thank you for emphasising that. Colleagues, are there questions for Steve? One from Ian, please.
Yeah, more just observations. So thank you, Steve, for your report. You mentioned in there the ED&I conference that we held, the first conference, which was a combined conference between our organisation and Cornwall Foundation Partnership Trust. I attended that day along with a number of board colleagues and staff members across, and it's great to see 200 plus people attended that. There was a real buzz. It was held here in the Knowledge Bar and in the Postgrad Centre. I think I think there's an after from it as well in terms of follow-up conversations that I've had and others have had. So that's something I just wanted to kind of pull out from it. And then echoing the positive comments in terms of the UEC performance, I happened to pop into ED last Friday and bumped into one of the consultants who reflected back to me that slight release in pressure, and I'll call it that rather than being quiet, because I don't think he's ever quiet, was allowing them to do some of the training and really important parts of their role that they really enjoy. So I think it is just worth us reflecting that under that continuous pressure, it's really difficult to get to some of those important parts as well. So it was really pleasing to hear that.
Very pleasing. Thank you.
Could I think that's really helpful, and I certainly echo those points in the Equality, Diversity and Inclusion conference that we held was fantastic. And I think it shows the commitment of colleagues from across our organisation and across the wider system that is important. And in the context of really challenged operational pressures, colleagues were still able to find the time to be able to be there. And a number of colleagues joined virtually where it was challenging to be there in person as well. So that was really positive. Just to add to the urgent and emergency care context then, we absolutely have more to do. It is certainly continues to be a challenging environment, but those performance improvements have been achieved in an environment which isn't about reducing demand. And in fact, our number of ambulance arrivals in the month of April was the second highest across the entire Southwest region area that Southwestern Ambulance Service Trust serves. So it's not a case that we've come out of winter, demand has dropped and that's what's enabling those improvements. It's absolutely about the impact and the actions that colleagues across our organisation and across the system are taking. So I think that's really important for us to recognise that the demand hasn't in any way eased off, so perhaps even more significant to achieve those sorts of improvements.
Yeah, which make a real difference to people's lives. Indeed. Any other questions? Yeah, Robin.
Thank you. Just to build on what Steve and Ian are saying there, I had a lovely phrase given to me by a colleague last week, which was, she said, there are ripples of positivity coming through the trust now. And one of the things that we've done is we reflected on the learning from the board development session on civility, and we implemented a mechanism of starting our site. We've changed our site meetings to site safety meetings, and we start them with everybody going around the room describing what they're proud of that day. And we're really starting to see that energy come, and it's nice to hear Steve, Ian there, you saying you popped into ED and you've experienced some of that positivity coming, and we're trying to take that on to the next level now with working with our colleagues from, they're called ESIS, it's Emergency Care Intensive Support Team, national team that can come and work with us to go through the organisation and do that piece of how do we relearn the speed that we used to work at to deliver the 4-hour standard? How do we really put that at the heart of what we're trying to do? Because we know as that ripple of positivity starts to come through the organisation, we will see yet more gains, and then it should start to self-perpetuate itself. So that's our very much our angle, is to try and create a momentum for the position we find ourselves in. But it's really reassuring to hear people using some of that more positive language when we're talking to them out on the wards. Long way still to go, but just nice to see that's starting to come through.
Yeah, it is, Rob, and it'd be really welcome to hear what our CQC colleagues say as the result of this next 48 hours of them being with us. So, absolutely. I've just got one question, if others have... Are there any other comments? So I've got a comment and a question, Steve. I think the comment about the Equality, Diversity, Inclusion conference is really welcome, and I absolutely echo what you said, Ian. And I don't want to be the bad fairy, and I do want to say, and we still are at the start of our journey, and I'm very aware that there will be colleagues possibly watching, but certainly in our trust at the moment, who are still experiencing behaviour which is not acceptable in any way. And so I want to celebrate what we're doing, and it was great to hear about the attendance. But I think the next time we hear about this at board, I'd like to hear that it's we've moved on from beginning, and we've got to some, so what's the next stage after this? And maybe it is going to be hearing from staff, or perhaps hearing from our networking groups of the various different groups there are. And maybe that would be a lovely board presentation to hear, actually, from chairs across both CFT and our trust. But I suppose I feel that we do often talk about making a good start, but I think it's time we went on from a good start, really. But that's not to diminish at all what you said. I have one question about the governance improvement plan, if I may, and it's under item 8.6b, which is in the appendix to your report, Steve. I think the first thing I want to do is celebrate our governance improvement, and that it is a continuing picture. And when you look at all of those things that we had to do and see how many we have now completed and that we're still working on, I'm genuinely proud of that, and proud of the team who've put so much work into that. People always think governance is boring. I don't. I think it's what keeps us safe. So I'm celebrating where we are, but I would just like to hear any comments, really, about how the executive governance structures are operating, because we're saying we want to propose it as complete, which may be the right thing. But I guess I'm seeking some assurance about whether what we hoped they would achieve is actually happening. And maybe it's not just you, Steve, but perhaps others as well.
Yeah, I might ask Lindsay to comment in a moment in terms of an update on the steps that have been taken. And it may be, Mary, that the actions we originally set out have been implemented, but in the operating environment that we're in, we may need to see further improvements going forward to further strengthen this. So we could give some consideration to leaving the action open for a further set of work to address that. But I might ask Lindsay to comment.
Thank you. Thanks, Steve. I would agree. We actually have an internal audit taking place with regards to our corporate governance at the moment. So therefore that will look at how it's been embedded and how it's working effectively. So I think that'd be a great idea to actually keep the action open and move that into the 24-25 governance improvement plan.
Are there any other thoughts or comments on that? Richard?
Not really to enlighten it, just to support it, really. I think that's a really good idea. Thank you.
Great. Thank you. So that's not to say we're not pleased with what's happening. It's just to be sure it's having the effect, as you say, Steve, because we're in a different environment now than we were when we set that up. Kim?
I suppose it's the recognition of the actions that have been completed as regards the many reasons why this governance improvement plan came about. So I suppose it's how do we recognise, and it might be that It might be that we close this set, but recognise that we've got the audit coming up that will lead to a further set of improvements. Otherwise, we won't be able to close down the last set of improvement plans, would we, if you were looking at it from a governance trail or a further inspection? So I suppose, Lindsay, very happy to work with you to say, how do we close down what was the last set of requirements, and how do we then reflect that this will be an ongoing piece of work following the audit? There'll be a 24-25.
Yeah, thank you, Kim. Did you want to respond?
No, I think that's great. I'm very happy to work with you, Kim. I think it's really important that we continually learn, and these things take a little while to embed, so that continuous learning is really important. So I'm very happy to transfer that over to the 24-25 plan. Thank you.
Hey, thank you. So, Steve, with your report then, we're asked to receive a note to the report, note the update on the governance improvement programme and agree the actions proposed complete and the extension of action B86B, sorry, and note the timeline, and also to note the actions being taken regarding the West Cornwall Hospital Urgent Treatment Centre. So if colleagues would be good enough to indicate you're noting in the chat, that would be very helpful, thank you, including colleagues in the room, sorry, for new people here, thank you. Moving us on to the strategy section of our meeting, Ella, our Chief Performance Partnerships and, oh, you've got such a long title, Transformation Officer, sorry, to take us through the quarterly report, please.
Thank you. I'm glad it's not just me that stumbles on that one sometimes. So in the board papers today is the strategy report, which we do on a quarterly basis, and this is the look back on Q1 of year 2 of our 10-year strategy. There's lots of numbers in that statement, but we have a 10-year strategy as an organisation, and we have in January of this year commenced on our 2nd year of delivery of that. So our strategic year runs January to January at present time. This paper went through our People and Cultural Committee and our Finance and Performance Committee last week, and had a really rigorous discussion and feedback from there, which I will share in a moment. Essentially, the paper outlines how we're doing against our 3 key strategic aims, and specifically the priorities that we pulled out for year 2 in order to get us along that 10-year journey. Each time we do this, we pull out a specific case study for a bit more detail, and this time the case study relates to reducing health inequalities across the Gypsy, Roma and Traveller communities, which is a piece of work we've been doing with system partners and has been really well recognised and received. So we wanted to share that here. Appendix B in the paper provides detail of progress at this stage, and you'll see, and as the committee's noted, most of those actions at this present time are RAG rated, so they have a red, amber, green status of being green. There is one exception to that, and we challenge ourselves a bit on that. We don't want to be over generous. However, it's important to note, rather than being specific outcome-led RAG ratings, these are about, are we taking the actions we said we would in order that we might deliver the outcomes down the line? So it's quite a tricky one to land that in terms of a red, amber, green, and we are giving further consideration following committee feedback around if instead we should be marking perhaps in a direction of travel on these rather than a kind of a binary red, amber, green. So any other feedback on that would be really welcomed, but hopefully through the narrative given, people can understand the intent and what has been delivered there. Also, if I can just draw attention to page 7 of the report, which shows a roadmap specifically for this 12-month period, but people may be interested to know that the entire 10-year strategy roadmap we commissioned a piece of work for it to be put up on the wall in the Trelawney wing of the Trelisk site. It will be replicated in our other sites as well. It arrived yesterday. It is gigantic. It's really exciting, and I think it'll be a fantastic way for our staff and patients, really importantly, to see what our plans are and what the key milestones will be over the next 10 years. So really would encourage people to go and see that when it's up. It should be up this week. which is a nice step forward for us. So feedback from committees, as I said, there was discussion around the RAG ratings and whether that's the most effective way. So we're going to keep that under review and consider also how we can, essentially the most important thing through this report is, are we able to tell people that we're on track or flag that we're off track towards delivering our overarching strategy? So that needs to be the key message that comes through, and we need to give careful consideration to how we do that. There was a suggestion we could link our priorities closer to our key performance indicators. So being clear on which things in our integrated performance report we're expecting to move and have a significant impact on through these actions, which I thought was really helpful. And therefore being a bit more explicit in the outputs that we want to see. And there was also a discussion at Quality Assurance Committee around linking to the quality aims that the Quality Assurance Committee have recently signed off, and we will be doing so for the next iteration of this report. So it's probably enough of me talking, and I'll pause there to take questions at this stage. Thank you.
Thank you very much, Ella. That's really helpful, and it did have some good conversation. Usma's put in the chat she's looking forward to seeing the physical roadmap, and so am I. That's going to be quite a thing to see and to share with others. Colleagues, I know there's a lot of discussion. Richard.
Thank you. I just wanted to comment on the case study, because it was wonderful to see a case study on Gypsy, Roma and traveller communities, and it's for me looking in, it was a really good example of community engagement where a lead GP with an interest is engaging with the communities on site and providing that really tailored support. I just wanted a little bit more information about. I could see the gains around bowel cancer and screening. I just wanted to understand what wider work we're doing around wider health improvement and promotion initiatives such as healthy eating, diet, tooth hygiene, and so on.
Yeah, thank you very much, Richard. Ella, are you happy to pick that up, or somebody else?
Yeah, I see Alistair's hand's gone up because he works closely with Rebecca Cave, our lead on this, so he might want to comment further from a clinical perspective.
Yes, I think the team have been very careful in the way that they approach this community. So I think they had to spend a lot of time building trust in that community, which they've done incredibly well. The work started off really on the back of the very high perinatal mortality rate within that community, and there've been massive gains in terms of reducing mortality in that sphere. And then they've expanded their input in terms of screening, vaccination, cervical screen, those sorts of things. So they're working with the community to expand beyond the women in that community, which is where it started, to the community. So it's a work in progress.
Thank you, Alistair. Kim, you wanted to come in there.
You can see Alistair and I are on the same vein. No, he covered what I was going to say. It started with some of the work, as he said, and those services are coming together to expand, but to maintain that trust and confidence.
Thank you, Kim. Adam.
Thank you. I'm conscious the first time I've spoken, so can people hear me okay? Yep, okay. And now I've frozen. So Ella's already said this very adequately, but just instinctively, in the context of what Steve and Mary have both mentioned, I think, in terms of the operational plan and the budget that we've just set and the challenges around that for 24-25 and into the medium term, instinctively, it doesn't feel quite right that we're flagging everything as green in the context of delivering a plan for 2032. So I welcome the fact that we're thinking again about how we bring this through committees and the board in future. But it just feels the way that we're presenting it at the moment, recognising all the fantastic work that we're doing, which is fantastic, and I love the case study. It just feels like we've got so many challenges that we need to find a different way of presenting this to board.
Yeah, thank you, Adam. I think that did come up through the committees, and I know you're going to work on that, Ella. Richard, I think you might have wanted to make a similar point.
It is for board just to reflect upon, because I think it reflects back to refers back to the last item where we looked at the governance improvement plan and the comments around 6B6 or B6B, whatever it was.
Anyway.
And then we might see it in the green plan as well. So it's just to comment on the themes. There is a tendency perhaps to get assurance around process and not necessarily assurance around impact. And I think the comments that from Finance and Performance Committee made back to Ella, and she's reflected them very well, so they've been taken on board, is we're rating things as green because what we said would happen has happened. We've put things in place. Whether that's making a difference is the question I think the board needs to be assured on as well. And so our feedback to Ella, which she's reflected, is can we have more on, we said we would do this, we said it would have this impact, and we can now measure the impact it's had. And I think that's true of a number of the papers that come up. There's more assurance on process than impact.
Thank you, Richard. Did anybody want to comment further on that? No, I think, as you say, Ella has taken those thoughts and will be probably coming back next quarter to share some thoughts. And I suppose my reflection is you are absolutely right, and I agree with you. And I'm genuinely pleased that we've got to this point in process. But it's all a journey of improvement, isn't it? And it's about saying, have we got the right building blocks so that we can do the work that we need to do? So I think, don't be discouraged, Ella. I know you're not, but I think we are just keeping going on the journey. Okay, any more on that paper? If not, could we please note that? But also, I guess perhaps what I'd add, could we also note the value of those case studies that we suggested in the last quarter? And actually, they're really coming through strongly. So thank you for that. And then it's your turn again on the Cornwall Health System Green Plan Annual Report.
Thank you. Yes, so this is our annual review. So a look back on the 23-24 year in terms of our green plan. I think people are aware, just to remind people, we have a system green plan, and we obviously have within that the RCHT specific commitments. And as a trust board, we took the step of declaring a climate health emergency, and we set ourselves the very ambitious target of net zero by 2030. We set that target to be aligned with our Cornwall Council colleagues, and because we as a board felt it was very important to be showing significant ambition in this area and making impact rapidly. Though again, this paper has been through our committees, and there has been had received good discussion. I think the theme that came out of that, it'd be fair to say, is around the ambition in relation to that target. However, I'll also just refresh our memories. Back in November, when the update previously came to Trust Board, because we do a 6-month interim report as well, we agreed that we would, from January of this year, dedicate our sustainability leads time to for a 6-month period, reviewing and refreshing our plan to come back to board with a really well articulated description of how we're going to make the significant progress as a bit of a stock take on that. So that work is underway. Heather's time is being dedicated to that work. So I think in terms of future assurance on delivery, I'd ask that we wait for that update, which will be coming through. So she's got a 6-month period, so the end of June, so in the summertime. And I think there will be decisions for us to take around which of our actions really are going to make the most impact. It's also been fantastic that we now have Brian Johnson here as our Director of Estates, because many of the actions that we need to take around decarbonisation of the estate require expertise in that area. He has past experience, and he's now getting actively involved in reviewing that plan with me, which is really, really fantastic. We discussed the fact at committees that the NHS as a whole has a target, which is to reduce, is an 80% reduction by 2036 to 2039. with net zero by 2045. So our trust ambition and the Cornwall Council ambition is significantly further than that. I think our sense is it's right, we're being ambitious, but we may just need to take stock around how are we going to specifically deliver actions. That's my kind of air of caution on this. We need to be really clear that we can deliver what we need to. And so as the paper outlines, our biggest risk there is that capacity and our investment that may be required in the future, but we're really dedicated to doing this. And I think hopefully what comes through in the report is RCHT is noted as being a trust that is doing a lot in this space. So there's fantastic work going on, and it's something that as well is really welcomed by our staff, which is really great to see people engage in this. They want to deliver on it. They really come, it brings people together, unites them. So I think it has a strong link to a lot of the culture work we're doing as well, which is fantastic to see. So I hope it didn't sound too doom and gloom there, because I think in the body of the report, there is a really positive story to tell. I just think all trusts and the NHS as a whole is flagging the fact that this is a really challenging ambition, but one that we are dedicated to. Thank you.
The words out of my mouth, really, because I was going to remind us that we have had and continue to have national recognition for some of the things that we are doing and that we are initiating. So I've got Ian first and then Usman.
Yeah, thank you. Thank you, Chair.
I think somebody's laptop microphone's on.
Somebody got their sound on.
Should be right now.
Okay, thank you. Oh, was it? Yeah, so just to follow on from what Ella said at the end there, I think there's some really good initiatives in there, and for individual groups of staff and teams, some really positive things in that report. I think for me, though, there's something about recognising the reality of where we are and where we can get to by 2030. And Ella articulated it really well there in terms of the overall NHS ambition by 2045. And it is true to say, and I think I mentioned it at last public board when we had this paper, that the funding to support the green ambition isn't yet materialising in the allocations to our system and ourselves as an organisation. That's not to say we shouldn't continue to press ahead with it. And I was minded to look at the council update, and on the council's website it sets out some of the key steps that they're taking over a period of time. So it sets milestones around having electric vehicles by a set date, and demonstrates the amount of carbon that reduces, and then about what we do with our buildings and the way we heat and power our buildings. So I just think as part of our roadmap and the update that Ella's referred to is getting some of those objectives and milestones, and we might have to accept that we won't get to a net zero position by 2030, but what can we achieve, and reset our ambition to then deliver against that is kind of my reflections on the report.
Yeah, that's really helpful, especially your point about the council plan and how we make sure that we do integrate with that. Thanks, Ian. Usma. I don't think you have to turn it on. I think it would, yeah.
Just echoing what Ian said, I was just really wanted to commend the initiatives that are in there. I think they're really very inspiring to other teams. And I was a bit disheartened that the staff-wide communications have been ineffective, because those initiatives are so inspiring that those should, help encourage other teams. And I wondered whether there was a way of quantifying the financial benefits of the initiatives that have taken place, because they might help that kind of communication of this is working, and giving people motivation to try it in their own teams, but also help us as a trust to move it higher up the agenda. So if we can see the effect that it's having on the bottom line as well as on morale and meeting those milestones, then so I don't know if there's a way of getting some quantifiable.
That's a really great idea, Usma. Thank you. I'm going to look at Ian. Is there a way of doing that then?
Yeah, very happy to work with Ella's team, and I'm sure we'll be able to find a mechanism to do that. Yeah.
Thank you. Adam.
Thank you. I'm possibly guilty again of echoing what others have said, but I love the work that's been done is fabulous, and the energy and enthusiasm of all the projects is brilliant. But recognising the challenge around the ambitious target, I just wonder whether we need to do more than just note this report, because we've said we need to revisit what we can realistically achieve by 2030. So Ella possibly may have said by when we will have a revised plan, but maybe we need to reflect that in our plan as a board.
Ella, did you want to come back on that?
Yeah, so certainly the intention is that the report that comes back from that 6-month review will have a suggestion, Adam, for board around what is achievable within what time frame. So I think it would be helpful that I can reiterate that from here today, that is what board requires. And yeah, I think I also wanted to say, firstly, with the Cornwall Council, we very much link in with them. So I think linking some of our key milestones to theirs will be helpful as well, in terms of sharing resources across the patch in Cornwall and making sure we're all pulling in the same direction. And then my other point was just in response to how we quantify some of the potentially financial benefits of this. So we talk about the triple aim, don't we, in this area? Again, that it is our intention to get better at that. I think one of our struggles on this is the capacity. So we don't have people dedicated to measurement of this, and some organisations do, and that's where we need to flush out for the next report for board. What resource considerations do we need to take into account if we're going to really be able to measure and demonstrate impact? However, there was an example this week, our performance review with one of our care groups who's really active in this area and a driver of our green plan. The care group general manager initiated the Green Ranger initiative in here, and very clearly making a link between that work and the hope that it'll impact on reducing sick days, which we then know in turn both has a well-being but potentially a financial impact in terms of how we need to backfill staff when they go off sick. So there are definitely examples of where you can clearly see there would be an impact. It's how to capture that. So we'll work closely with the finance team, we'll learn from others, and our intention is certainly to be in a place where we can quantify impact much more.
Thank you very much, Ella. Steve.
Yeah, it just builds on that. That's really helpful, Ella. So the next report would be scheduled to come to the board in November 2024, and I think that there's quite a significant amount of work in what you've just described. If that timeline did fit with board's expectations, I just wanted to check with you, Ella, if that would give us sufficient time to undertake the kind of level of review we've just described. With because I can see if that did come back in November to say we've undertaken a detailed review, this is our confidence level in being able to achieve net zero by 2030 based on this forward action plan, or if there is a gap or risks or kind of resource decisions to be made, that would be quite timely to have that in November to inform our next year's operational planning. I'm just testing whether that gives you enough time with the team to undertake that level of review.
Yes, I think that does. As I said, Heather is our full-time person on this, but only till the end of June at present time. I may need to consider that again. She was working across Flow and other initiatives, and as always, we're balancing priorities. So I think November would be good timing. As you say, it enables us then to feed into system operational financial planning round.
Okay, and we did note that, I know, at the last quarterly report about the use of the person's time. Kelvin.
Yes, just a bit of a build on Steve's comment, really. I think the key to answering those questions is actually to build some of the estimation capability, because obviously the report at the moment is still relatively conceptual whilst reporting some good initiatives. So I think we'll need to support around how we gather the data. There are some useful bits of data out there at the moment. I know the outpatient transformation programme have made some good efforts estimating the effect of the patient portal and reduced patient journeys. But I think we probably need to put all those things together to get a broader picture.
Thank you. Usma, is yours a legacy hand? I think it is. Yeah, no worries. Okay, so I think what we're saying is rather than just noting the progress against the plan, I think we are noticing the progress and welcoming some of the progress. I think we're also saying that we want to take the opportunity, as Richard and Adam written in the chat, we're about halfway through a 21-26 strategy, so it's a good point to pause. So I think we're going to suggest that we use the next quarterly report, as has been described by Steve, to take that review of where we are. But we are also asking that we might show the financial effect of what we're doing more largely, and we're asking that we link the milestones with the council's milestones. I think that's probably all that we've said. So on that basis, could we acknowledge and note the report with those additional comments? Thank you. Lindsay. So moving us on then to item 10. These are beginning now our quality and safety and high quality care section of the meeting. And as I have said before, but want to say again for the benefit of people who've not been with us before, a lot of the work of this board is done by our committees who have the opportunity to look in more depth at some matters specific to their topic. And so the way we now do the work on the board, and we have been doing for some possibly even a year now, is that we ask committees to provide us with a report as to those matters which they've considered, what they're satisfied with, and anything that they feel they need to escalate to board attention. So this is now the first, Isabel. You're the first of these. So we're going to have the quality assurance report, and then following that we will have 2 or 3 reports that have been to your committee, but are reports that need to come to the board. So if you could introduce your report, please.
Thank you, Mary. Yes, hopefully my microphone's working. So the Quality Assurance Committee, which we tend to refer to as QAC, which may be a bit unfortunate, but that's how we refer to it. But certainly we're talking about the Quality Assurance Committee. We actually have 2 meetings for members of the public that aren't aware. So we meet as an organisation purely for RCHT, but we also have a Part 2 meeting with our colleagues in the Community Foundation Trust. So this report reflects the activities of the committee over the previous 2 months. You will see from the length of the report that we cover a very, very broad agenda with lots of items, and it's an extremely busy meeting. And I would like to thank all my colleagues who are part of those 2 committees for the work that gets carried out there prior to anything coming to board. So the purpose of this is really just to summarise any decisions that were made, and also just to flag up some areas where we really felt we only had partial assurance around certain things. So if I was to start really with the Part 2, which is our joint meeting with Community Foundation Trust, I think there are only a couple of things I wanted to highlight. One is that as a consequence of all the work that's been done between the 2 organisations over the preceding sort of year, 18 months, and Kim will correct me, it may even be longer, I think we've received lots of really important reports for the committee to consider that are around the integration of services across the 2 organisations. So as an example, the safeguarding strategy, and also recently the domestic homicide review process, and also picking up on things that are very much around the system. So those meetings have been really informative and really helpful, and we've been able to do some very interesting deep dives into certain things. I think, just to summarise the Part 2, I think both organisations have now really clearly expressed a wish to move towards a more collaborative, system-wide quality improvement committee. And as Steve mentioned in his report, there are plans to establish that, and the first meeting is due on Friday. So we will be coming together in a joint committee with our ICB colleagues, as well as colleagues from CFT and ourselves. So looking forward to that, to see how we expand on the work that the 2 organisations have been doing. And very clearly, a lot of the quality and safety work that takes place really does have to reflect a system-wide perspective. So we're looking forward to that. And as I say, both organisations have been very supportive of that as the direction of travel. So moving on to our own quality committee, I'm not going to go through the very lengthy report that you've got in front of you, but I think there are a few highlights I wanted to flag up to board. The first is that we're really pleased to endorse the voluntary services strategy for the next 3 years for onward approval, so it will come to Trust Board for approval. So that was a real positive. And then I think there are a few areas where we felt we only had partial assurance, one of which was the recent quarterly report, Learning from Deaths. And I know that Alastair, as our Chief Medical Officer, is going to come back to committee to provide further assurance around some of the aspects of metrics for other liver disease, which I know the assurance really comes from the great work that's done by the Mortality Review Group. So we will receive that at our next meeting. I think the other area that we did not feel we had full assurance in March was the number of overdue incidents reporting through the Incident and Review Learning Group. So again, we've asked that group to come back to monitor that over the next 3 months, and if needs be, we will ask them to do a much deeper dive into the reasons behind some of those delays. And then really, I think the areas that came up in our most recent meeting in April, first of all, a very real concern around the potential risk with quality assessing the impact of the cost improvement programmes that are planned for the coming year. We are really keen to seek further assurance around those schemes. And particularly, I understand that all schemes over £50,000 will be quality impact assessed. We're also asking for some consideration of those programmes which are less than 50,000, because of course, we don't know that there wouldn't be a safety and quality impact on those schemes. So we'd like a bit more of an overview of those schemes. And we do acknowledge that there wasn't really a lot of work done in the last year around quality impact assessment. So the committee wanted to flag up to the board that there is a legacy risk potentially of work that was done over the last year. Ella, I think, has really covered the other point I wanted to make about the strategy, and I really want to thank her for coming to committee and talking that through with us. But we're really keen to make sure that the quality priorities that are outlined for us in the coming year is aligned to our overall strategy, and perhaps just made more explicit in the way that we report around our strategy. So I think those were the key things that I wanted to flag up. The report is there to be read, and thank you very much.
Well, thank you very much. And I go back to what you started with. This is a very heavy committee. It covers a lot of ground, and we're grateful to you and the members of that committee for doing that. So thank you for the report. Are there questions for Isabel at all on that report? You've done too good a job, Isabel. Okay, I think I would also, though, note the importance of the quality impact assessments that you've raised. I think everybody is concerned about that. And I might be wrong, Steve, but I think I'm not. That was picked up at the system meeting yesterday about the operational and financial plan.
Sorry, I should perhaps have just added to that we're really conscious from feedback from the Finance and Performance Committee that what we don't want to do is introduce long delays. That there is an urgency around pace. Richard is looking at me and nodding, so I know that he'll be really keen that whatever work is done to look at this doesn't delay the really important operational financial progress that we need to make.
We're already in month 2.
We are.
Okay, thank you. Richard, were you wanted to come in? No, you were just agreeing.
No, I'm just agreeing. I think when we look at the SIP savings, we've got to make cost improvement programme savings in the plan that we're submitting. It's around 29.5 million, I think, of which 60% has to be recurrent. And therefore, if we have delay, it's right and proper that each have a quality impact assessment done. But we've got to make sure the process is rapid and smooth to get that through in order to keep the work progressing.
I think Kim's just about to give us some assurance on that. Kim?
So I think it's really important that we're doing some education and housekeeping around what EQIAs are, equality and quality impact assessments. They're an integral part. Unfortunately, the way it's worked across, not just our organisations, but others in the system as well, is they're being done almost post the event, which we will absolutely not hold up in any shape or form, but noting that a lot of these will continue for year 24, 25, 25, 26. We're going to get ahead of the curve to make sure that they're part of the plans before they're submitted, so we get ahead of ourselves. So it's just noting that, but we've already started some of the meetings with Alistair and myself, going through some of the investments and the EQIA, so that process has started.
Thank you very much, Kim. So if there are no more questions for Isabel, thank you. We're now going to pick up point 10.1 and 10.2, the first of all, the Maternity and Neonatal Safety Monthly Report, which is a report reserved to board, although it has had a very good discussion. And so, Kim, if you would like to highlight only the key points that you want to bring to board, please.
Thank you, Chair. So absolutely, this has a huge discussion part of our Quality and Assurance Committee, and it's outlined in Isabel's Chair's report. Just a few things to bring to board's attention. It was, we spent a lot of time talking about the 7 patient safety incidents that had occurred during the month of March, which is quite a high number, all considered. At the time, there were no themes that were identified, but the maternity group had an exceptional meeting just before our Quality Assurance Committee, and was specifically looking at the number of full-term babies that were attending our neonatal unit, and further understanding that. Some of them were for cooling, as is expected, and sometimes as part of that process and in line with national guidance. However, there were 2 cases identified where a customised growth chart was absolutely completed in line with our policy, but it was felt that they were not appropriately escalated, and there's some team work being done and continues to be done with the team to make sure that they are now discussed, escalated appropriately, and we can gain assurance from that. So that was a really strong part of the discussion. I'd like to do some celebration as well, considering it was a really sobering read for everyone. 2 of our obstetric consultants were awarded Mariposa Awards, one for special recognition to services and one for outstanding contributions to services. And one of our maternity support workers was awarded a Chief Nursing Officer for England award for her outstanding care. So we did have some good celebrations in the month of March as well, noting that this was significant progress on recruitment, both for maternity support workers. We now have 0 vacancies, and we had 7.6 whole-time midwives vacancies, and we now have 5.2 in progress. So we're looking currently at reviewing that risk score. And the same can be said for transitional care. Some real significant progress in recruitment has finally happened in that area, which was really pleasing, but doesn't detract from some of the other recruitment areas that we have, and those will be progressed through investment committee and recruitment. And the only other thing to note was our neonatal unit was closed for 6 days during March. They had a rhinovirus outbreak, which is a respiratory virus outbreak, which was very well managed collectively, and it was up and running again. And we had the support of our wider system in the region to be able to cope and look after those parents and babies, and all have been transferred back into our care. And I shall leave it there.
Thank you very much, Kim. And I know there was a very good discussion at committee, but colleagues, are there any further comments or thoughts? I just will highlight what you were saying about the awards. I think the award for the nurse was quite remarkable. We shouldn't underestimate. This was a national award and really very welcome. But also to celebrate the work that you are doing with others on the recruitment. I think we've been worried for a long time, haven't we, about that? So thank you for that. Any other questions, Ian?
Yeah, just one perhaps to help me understand, Kim, in terms of the incidents, and you mentioned the exceptional MDT meeting. In terms of external input to that, do we get that on a regular basis in terms of ensuring that we're getting a different perspective from outside of the organisation?
Yeah, so we have the perinatal mortality review group, which looks at every incident, and there's wider system as well as regional attendance at that. We also have our local, we also have our system local maternity and neonatal system review group, and that's part of that. So there's quite a few touch points across maternity that has that external review, and that's why we're very, very keen, and there's many peer review teams that go in to be able to give that wider fresh eyes approach as well.
Thank you very much, Kim. Andy?
Thank you. As the maternity safety champion, responsibility to the board, I think it's important to note it's very sad for the individual families affected by these incidents, and I feel very huge sympathy for those families that are involved and affected. Some months there are few incidents, and some months there are more incidents, and I think that's the nature of obstetrics and the service that we provide. My responsibility is to keep a very, very close eye on these incidents and speak to Kim from time to time and to get a better understanding of the trends that occur with incidents over a longer period of time, because, as I say, the numbers vary month by month.
Thank you, Andy, for what you're saying, and actually for undertaking that really important role on the behalf of the board. We value that, and I echo what you're saying about these incidents and what they mean to a whole family, and what we also know, because we see it in other reports, is some extremely good work that our bereavement teams and others do on behalf of families. Not that makes it better, but that we do have them there to provide some support. You want to come back?
Yeah, just say also not to underestimate the effect it has on our staff as well, and the support they require, need when these events occur.
Thank you. Thanks, Andy. Anything else for Kim? Kim, did you want to come back?
Yeah, and that's the importance of having a non-executive. So Andy, and prior to Andy, Isabel are a really important member of our neonatal and maternity safety champions group, and that meets once a month as well to have a look at some of these issues and trends. It's also important, that's why we look at, especially at Quality and Assurance Committee, a summary of cases over the quarters as well, to make sure that we are not complacent. And Andy's right, it's a bereavement is something a family has to live with for the rest of their life. It doesn't detract, so that all of those support services that wrap around both families and our staff are equally important for mental health and well-being. Or if you've had a traumatic birth, that you're able to get that support, especially if you're going to have another pregnancy. And I know you and I met a very courageous individual earlier this month to explore lessons learned, but most importantly, support going forward. So it's never detracting from that.
Thank you, Kim. Perhaps you'd like to mention the REN nurses and what their role is?
Yeah, sure. So we have a team that is for women requiring additional nurturing, and they're a very, very very, very integral part of supporting women who have had trauma, and how we support people through that trauma. And most importantly as well, make sure that they have that wraparound, not just during their pregnancy, after their pregnancy, and during their pregnancy, prior, during and after, but just making sure we've got that shared learning for the most vulnerable in our communities as well.
Thank you, Kim. I'm just realising that really very helpful piece of feedback we received from the individual whom we met. That lady actually approached me as a result of that International Women's Day talk that I did. So we never quite know when things are going to come round again. Thank you, everybody. Any more for that report? In which case, could I come to Alistair? I've already said I got a bit lost in the acronyms there, so perhaps you'll help me.
Yes, certainly, Mary. As Isabel's already outlined, we go through this report regularly at the Quality Assurance Committee. The things to pull out from this report and generally are that RCHT's crude mortality is relatively static at the moment, but the hospital standardised mortality ratio has decreased in this quarter 3 to 101, which is a steady improvement over the course of the last year. And when we compare ourselves with our geographical neighbours, we're the 3rd lowest in the region for crude mortality and the 7th lowest for hospital standardised mortality ratio. One of the things the committee asked us to do was to compare ourselves with other rural trusts, not just our South West trusts. And we did that in this report, and it's in Appendix 7, and we're certainly in that plot, we're not shown as an outlier in matched rural communities as well. Over the course of a year, we get alerts about mortality from various different parts of our hospital. This is something that happens in all hospitals in the country. We benchmarked the number of alerts that we have versus others, and in the Southwest, and that's in the appendices of the paper as well. At any one time, a hospital might have between 0 alerts and up to 10 alerts, and these come and go, as have ours over the last few years. There are a few alerts which have come back. So we had an alert previously on fractured neck of femur. I chair a fractured neck of femur improvement group, and the mortality has been falling in this and fell down to below 100, but has started to rise again, and we've reinvigorated that group to look at what else we can do in that group. And we touched on other liver disease in Isabel's summary. Other liver disease is an interesting ragtag group of liver diseases that aren't alcohol-related liver disease and aren't cirrhosis-related liver disease. There are a multitude of different liver diseases that don't have one specific code. So the team have done an initial deep dive into the 15 patients in that alert. At the moment, the SJRs, the mortality reviews, have not shown any consistent theme, but the team are continuing to do some work on that. And as we said before, that will be come back to the next meeting. Other things of importance, I think we, as a system, we've got ahead of the curve in terms of our medical examiner system, service. We are now, our medical examiners are made up of a group of both secondary care and primary care physicians, and in this quarter, 94% of the deaths, the inpatient deaths in RCHT, were reviewed by a medical examiner, and of the ones that weren't, those were 67 cases which went to the coroner, of which the coroner has taken for investigation 48 of those. I think in terms of the rest of the report, I think from a positive, in terms of our quality improvements from the work that this team does, as I say, this paper is written through a lot of the work that the Mortality Review Oversight Group does, and it gets reported through to the Clinical Effectiveness Group. But our Deteriorating Patient Oversight Group also reports through to clinical effectiveness, and we've now started to roll out Martha's Rule across the trust, so that for relatives and patients who are concerned that they may be deteriorating, they have direct access to our critical care outreach team, and that's been successfully started to roll out through our cardiology wards and is slowly rolling out through the hospital. And also, we've revamped and changed our chest wall injury pathway with the help of our major trauma team, and that's working well at the moment. And previously we've had HSMR alerts around fragility fractures, and a lot of those fragility fractures were related to our frail elderly with chest wall injuries. So that's shown a significant improvement in our HSMR. And I believe that the latest HSMR for that is down at 78, which is well below the 100, which is the median. I think there's a lot of information in the rest of the report, and in the interest of time, I'll leave it there. But happy to go through any three-letter acronyms that I may not have missed, Mari.
Absolutely helpful. Thank you very much, Alistair. Have people got questions for Alistair at the moment? No, it is pleasing to see where we are with the mortality. I'm not wanting to cause extra work, but I wonder whether the committee also might think about looking where we are nationally as well as regionally, just for comparison, but that's not for today, clearly. And one thing that I was wanting to pick up was, I think it was at our last board, it might have been a committee, we talked about the number of our staff are being called to go to inquests, and I think it's item 7 on your report here, and what support that we are able to give them, and also the impacts of the time that they're having to spend at courts. Have you anything further to update on that?
Yeah, so as it says in the report, the nature of the care we're giving, the complexity of the patients that we're dealing with, and the detail in which the coroner is currently looking at death, have led to an increase in the number of coroner's inquests that our staff are being asked to get involved with. Now, the coroner during COVID has altered the way that he does a lot of inquests. So often he can just take the written evidence that we provide and make a determination on the basis of the written evidence. And that was certainly a very positive move forward for our staff. But we have also seen an increase in the number of face-to-face coroner's inquests that have required our staff either to be face-to-face online during COVID or face-to-face now that those restrictions have passed. We have a team, and our governance team, our patient safety team, and my team are at hand to help individuals with their statements and support them during the coroner's inquests. Obviously, that can be for somebody who's not been to the coroner's court before, they can be quite daunting. But I think the coroner is there to do a really important job for us and to ostensibly delineate the cause of death of these patients and make it clear. That's his primary role. But also he has the ability to instruct us to make improvements to our care, which I think can only be a positive if those are made aware. So I think it's a really important part of the work that we do.
Thank you very much, Alistair. I've got Steve, Kim, Uzma, you might make your point that you've made in the chat, and then Aled. So Steve.
Yeah, thank you. I just wanted to add to Alistair's comment about Martha's rule. The NHS England nationally was seeking expressions of interest from trusts to take part in the role that Alistair's just described, and it was really, really positive that NHS England, I think, updated us only over the course of this week that we were successful in being one of those first trusts in the country to be able to be part of progressing that. So I'm sure we'd all lend our support to that.
Thank you very much. Uzma, do you want to pick up your point on that as it follows?
Yes, just to find out a bit more about the rollout and how that's being communicated to patients. So is it starting in certain departments like ED?
Yeah, so it started in our cardiology wards. So posters, leaflets given to the patients as they arrive on the ward. So we've got posters on the walls. That's a stepped rollout across the whole trust. Within the I got some feedback after the first month, and actually patients were aware of it, but actually we hadn't had anybody escalated through that means, which is positive. But I think people were worried about instigating Martha's Rule, that it would lead to a huge amount of work that would be escalated, and actually across the country that's not been the case. And what we find is people use these things really sensibly. So the team are working with comms, with our teams, and the teams on the ward, so that they all understand what's going on. So this is a steady rollout through the rest of the hospital.
Are there any case studies in those leaflets so that people do get, they can instigate it if they have any worries, and it's not going to lead to this big.
So it's early days. So this started in February. The Claire Blake, who's one of our leads for this, who works in our ACCT care group, that's a critical care and theatres. She's leading on this. We can certainly make sure that case studies and things are brought back through the deteriorating patient group quality assurance in the future, as and when those good news stories or learning is derived from this. So yes, absolutely, that we'll plan to do that.
Thanks, Uzma. Thanks, Alistair. Kim and then Aled.
So, Uzma, the information leaflets for our patients also went through our quality standards network as well. So it's easy and simple to read, so people can follow, which is really important as well. But my point was also going to be on the support for staff and the support for our legal team. We have got huge cases coming up through, as Alistair said, and very complex cases coming up through the coronial or other areas. So we're very conscious of the pressure that's on our legal team colleagues, as well as that additional support that we give our staff members to be able to prepare to go to these, which we make sure and network and then do a follow-up post the event to see if to check that they're okay.
Thanks, Kim. Really important that. Aled?
Thank you, Mary. And thank you for the report, really interesting and comprehensive. I'm just thinking around the complexity of the report, actually, in terms that you've got instances of acute mortality and also instances of more long-term outcomes, such as the lung survival rates and lung cancer and bowel cancer. So I'm just wondering, in terms of assurance around learning from those, I can see good examples in the report around learning from the acute mortality, if you like. What about the long-term learning around, sort of survival and overall sort of outcomes in terms of those more chronic instances?
So the Learning from Deaths report is about learning specifically from death. The clinical effectiveness group there's a clinical audit programme which looks at a whole range of national audits around survival rates for various different conditions, the National Hip Fracture database, for instance, the aortic graft survival rates, etc. All of those national audits are presented through the clinical effectiveness group, and learning from those is pulled out through that particular group, Aled. So obviously that's survival rates as opposed to this particular report, which is specifically focused on learning from deaths.
Thank you, Alistair. Andy.
Thank you. Just going back to the Martha's Rule, is it possible for the board to see some of the posters and leaflets, just out of interest? And I just wondered, are they publicised on the general trust website?
They'll be in the documents library, but we'll make sure that we can circulate those.
Yeah, good idea, Andy. Thank you. Okay, everybody, I think we've had a really good conversation about Item 10. I'm not going to read out all the things that we wish to note. You have them in front of you, but could please, colleagues, note Item 10, 10.1 and 10.2. And that will bring us to Item 11, our Guardian of Safe Working Hours annual report. And we've got Sarah Coulter with us, who is going to present your report. Sarah, welcome.
Hi there, good morning. My reception's not been very good here, so could someone send me a message if it does start to cut out, please? So this is the report from 2023-2024. Ups and downs, I think, as we expect nowadays from the NHS and from junior doctors. And whilst I was getting really quite worried towards the end of Q3, I think, and Q4 was equally as bad, but we've had some really positive steps from the oncology team and the oral and max facts team. They've made quite significant changes to their work schedule for the junior doctors. And reading my report again today, I don't think I highlighted just enough the oncology specialty lead and the oral and max facts specialty doctor, just how hard they've worked to achieve this. We obviously haven't seen any change yet. Things were changed at the beginning of April, but I'm hoping for next year that we will see the improvement there. I'd also mentioned in the report that we were worried about cardiology in the middle of the year. I've spoken to the cardiology specialty lead, and it wasn't by accident. Things had improved there as well. They'd taken on board the learning from the exception reports and made changes within the ward, within the teams, made sure there were no vacancies and any gaps, and they were proactively filled if they were. Immediate safety concerns, we've only had one, and that was in oral and max facts. Incidentally, it had nothing to do with staffing or hours worked and has been dealt with internally. The rest facilities, I think this is another positive this year. It has been a long time coming. It's taken quite a few years to get to this point, but we do now have the 2 on-call rooms that have been kitted out with 2 beds each. They've got everything there is ready to go. We've also got the clear access now to the on-call rooms in the paediatric department, and we also have access, well, the junior doctors have access to kind of emergency rooms in the case bar if they're too tired to go home. And this was a major issue that was flagged in the rest facilities audit. So now that everything is up and running there, we'll be re-auditing just to make sure the junior doctors are happy with the rest facilities that we have out of hours. Yeah, that's probably just my quick summary, but obviously very happy to take any questions.
I absolutely endorse what you're saying about the rest facilities. It does feel as if it's gone on forever, doesn't it? So really pleasing to see us there, but also pleasing to hear what you're saying about the extra efforts that have been made on the behalf of some colleagues to ensure we've overcome some of those ongoing difficulties. So thank you very much for your report. Have colleagues got questions for Sarah? Robin, and then Aled.
Thanks, Mary. Thank you, Sarah. It's really positive to hear that cardiology story, isn't it? That they raised the exception reports and actions have been taken and address that. Do you think there's a space for us to think about how we promote that actually people using the mechanism as it's supposed to be has resulted in delivering the change? And then are we well promoted the great work that's happened? Because actually, Sarah, that's been a massive piece to move those rest facilities forward. So colleagues are well aware that you've managed to get that over the line now, which has been no mean feat, to say the least.
Yeah, I mean, it's interesting. As I was rereading the report this morning, when I was reading about the exception report survey, that there are still some barriers to exception reporting. I think it is worth putting the positives in place, that we've had improvements from cardiology, oral and max facts with oncology. Sometimes it's small changes that can make the difference. So I think we just need other departments to be aware that exception reports are not your enemy. They can be used to make positive changes and give a bit more ammunition to get extra staffing as need be. So yeah, I think that'd be really helpful, and I can put something together there for my consultant colleagues and yeah, the senior management. Yeah.
Thank you, Sarah. Aled.
Thank you, Mary, and thank you, Sarah. One part of the report that really kind of struck a chord with me was on page 8 around the more senior grades and exception reporting. So it states there that 50% of senior grades don't do exception reporting, and 25% of that 50% state it's because they fear negative repercussions or that they won't be supportive. So in view of our strategy around civility, respect, and dignity in work, I'm just wondering how that is being addressed, and yeah, is it being kind of mapped across the freedom to speak up work, etc. Thank you.
I think it's a tricky one. I think exception reports haven't been around that long. I think it's only been about 7 or 8 years. So a lot of the consultants won't have grown up with them. They won't understand the importance of them and how they are not negative. I think the tide is definitely turning. When we did the survey, a lot of them said they didn't know how to access this. I do all of the inductions and we do tell them how to access it, but I'm equally very glad that they get so much volume of information at induction. I think we just need to try and find a different way to get this information across to them. And I think it's not only working with the junior doctors, it's working with the consultants as well, just to encourage it and stop it being quite as taboo as it was. I think we're getting there, just not where we would still want to be.
So there are actions being taken around that?
Yeah, certainly from an induction point of view. And I think what we've all noted is, like I said, so this information overload at induction, and we're trying to get as much as possible on the junior doctor shelf, which was inactive for quite a period of time. That's been active now since about August of this year. So we're just trying to get as much written information there. So even if their take-home message at induction is, please look at the junior doctor shelf. And equally, I always say induction as well, if you come across any barriers to exception reporting or if you're discouraged from doing it, please contact me. They can't necessarily do that anonymously, but I can keep the contact anonymous.
So that second part of Alad's question about the crossover with the freedom to speak up, how are you able to track that at all?
I probably can do. Despite me saying, please contact me if there's any barriers, I've not had a single email in the time I've been doing this, which has been 2 years now. Yeah. So I think it's sometimes a case of I don't know what I don't know.
And you can't, Sarah. Yeah.
No.
Okay, thanks very much. Steve and then Ian.
We might also be able to take that question to our next agenda item with the Joe joining us for the Freedom to Speak Up annual report. I just wanted to acknowledge, Sarah, your leadership. And I say this recognising that we're on a journey and we have further improvements to make. But just on those examples that you've set out in the report, oncology, oral and maths facts, cardiology, rest areas, that they all have a direct positive impact on our junior doctor workforce. And the role you play is critical in enabling that. So I wanted to say thank you on behalf of all of us for those really significant changes. I think we're incredibly grateful for that progress.
Thanks.
Yeah, absolutely, Steve. You're quite right. Andy. No, Ian, I beg your pardon, Andy.
So thank you, Sarah, for the report as ever. Just on that question that was raised in terms of the grades, I wonder, is it possible in future reports to highlight that in terms of where the exception reports are coming from, so we can start to see if that trend improves? Don't know if that's possible.
It's extra work, but yes, it's possible. I will have a look for next time. Yeah.
You'll be asking for extra resources next, Sarah. So, okay, colleagues, thank you. Anything further? Sarah, you've heard what Steve said. Can I add my thanks? It's a really important piece of work that you do, and it is additional to what you do every day, I know. But I think this role, and it'd be lovely if you could stay for the next item, there's something about the leadership of these kind of roles that makes the difference. So it's the way it's done as well as what is done. So thank you very much for that. And if you would like to stay for the next item, which is our Freedom to Speak Up annual report, you would be incredibly welcome, but we would understand if you are not able to. Colleagues, could we receive and note the annual report from our Guardian of Safe Working Hours? And move on, please, to Joe Burton, who is our Freedom to Speak Up Guardian, to present the annual report of our Freedom to Speak Up work. Joe.
Hello. Thank you, Chair. So I'm going to assume everyone has read the annual report. And I bring with me today as well a story, a Freedom to Speak Up story. So I'll just highlight some main points from the report before we go on to listen to that, and perhaps take questions after that, Mari, if that's okay. So I just wanted to highlight from the report again that we are continuing to see anonymous cases. And actually, if speaking up is business as usual and our colleagues feel comfortable to raise concerns, we're less likely obviously, to be seeing those anonymous concerns being raised. Secondly, we've got a really thriving network of Freedom to Speak Up volunteer champions now. So we've got 55 currently working as champions on top of their day jobs. I meet with those champions on a monthly basis. They come from a diverse range of backgrounds. So the hope is that all of our staff could feel they could reach out to one of those champions. And obviously the key with the champions is about kind of their breaking down barriers by promoting speaking up all over all 3 of our hospital sites. And I've noticed in the last probably 3 months an increase in kind of referrals from the champions. So it's just to note really that the champion roles are really working. And then thirdly, just to end on this note, really, that really positive when colleagues come to see me to raise concerns, that what I'm getting is positive feedback when we close those cases. But actually what we need to see is this replicated within the care groups, so that all of our staff feel able to raise concerns, locally where they are working. So I think if we could move on to the story, that would be great. Thank you.
So thank you everyone for coming today to do this voice recording. My name's Jo Burton. I'm the Freedom to Speak Up Guardian. And actually it's so important that there's an alternative person for people to come to speak up if they need to. And I had the pleasure of meeting this person who's going to tell us about their Speak Up experience today.
And I'm Peter, and I'm going to be asking the questions today. So my first question to you is, without identifying the people or teams involved, what did you feel you needed to speak up about?
Okay, thank you for this opportunity. When the incident happened, I felt broken because right deep down inside me, I know I go about my job to the best of my ability to satisfy the trust that has been entrusted on me to do quality patient care. And I discovered that where I worked before, I used to be in a management role, and I know what office gossip, the implication, the kind of harm it can do to you. So I felt broken, and I went home really down. I had sleepless nights, and I had this intention of, let me just go tender my resignation so I don't get to see all this kind of incident again. I now got an advice from someone that really you can have your voice heard. I went online. Before then, I was getting mails about freedom to speak and opportunity to express yourself. And I saw this. I just walked up here, started asking questions, and I came because I really love my job and I still want to give the best out of me. Having that in mind and working won't give me the kind of results I want. So I just felt, let me just pick out, talk to somebody, and which I did, and I got results.
Thank you so much for sharing your experience. It sounds like a really hard thing to deal with, and hopefully things are better for you now. I'm just wondering how you found the speaking up experience.
Fantastic. I never believed it would get to this point of success. I thought it was just normal one of something that you just speak, and because of, pardon me if I say the color of my skin, it would just go around the circle and nothing happened. But to my greatest surprise, I was shocked when I got here. She listened to me. She explained everything. She asked me the options that's out there. I said, it's open. All I just needed is for a round table between me and the other party for me to say what happened, and we'll come to a conclusion. If it was my fault, I have to apologize. But it got to a point, and I saw an email from a higher authority in the chain of my work line, and the next thing I got a call from him, and for me at that point I just felt so my issue was taken serious. And that gave me the more energy, the more vigor to bring out the best in me to do. And that has really helped me, because beyond that, I think he did his investigation before he called, and he got a positive response about me. And I've given my all to the trust. I've even come to a conclusion. I now volunteer with the radio station here. And it has been awesome because I'm now relaxed. I'm working. I see everybody as my friends and easy, because I was assured that just do your job, you'll be fine.
Amazing. I imagine it felt quite difficult going to speak up. What advice would you give to others about going to speak up if they feel that they need to?
Yeah, I think why I decided to do this is just to encourage people. If you don't say something, nothing will happen. If you don't speak up, the management will not know what is happening down the road. I spoke and a lot has happened. So many things that I don't know has happened. There've been changes in my world. People have they've done a 360 turnaround from their past, the negative way of behaving, to being positive, being friendly to people. So my advice to everybody, no matter your skin color, where you're from, if you have a problem, speak out. The management are trying to get everything solved. If you don't say something, nothing will happen. Speak out. Go online, check your emails. You'll see the addresses that you need to. Regularly, I get emails from the communication team telling you different areas that you need to contact. Check your email, ask questions, speak out, don't die in silence. If you don't say it, solutions won't come.
That's a really powerful message. Thank you so much for sharing that. With us as well, we've got Gabby. Gabby, can you introduce yourself for us?
Hi, so my name's Gabby Rack and I am an organisational development partner with the Trust.
What are we doing within the organisation to make speaking up easier?
So we are a champion of our People Promise, which is being rolled out across all NHSs in the country. And part of that is that we each have a voice that counts. Under that, we have the rollout of our Severe Team Respect programme. So as a leadership programme, we've got the Safe and Compassionate Leadership. And then for all staff members, we do Let's Talk sessions on Severe Team Respect, which is about what we've just been speaking about, that self-awareness piece, understanding how we might be coming across. And we're also we're supporting at the moment with our new refreshed trust values and our new behavioural framework, which is being rolled out, which we're trying to essentially support the rollout of our organisational culture and really get that right. And part of that is about championing speaking up. And as part of that training package that we're going to be rolling out, it's about how to have those conversations when we don't get it right, so those conversations are really productive and proactive, and that colleagues feel that if there is a bit of incivility or if they're not being treated as they should expect, working at RCHT, colleagues feel empowered and they can take account to be able to have those difficult conversations, and we're going to give them the skills and equip them to be able to do that. But also, that's the negative side of it, but also we're going to be launching values nominations, so actually we can really celebrate where we're getting it really right. When you're experiencing respect at work, where you've got that compassion, that honesty, that teamwork, really celebrate our successes, because we want RCHT to be a fantastic place to work. And through getting this input, all of this is really important to us. If we're not getting it right, we need to know. And if we are getting it right, we also equally need to know. So we need to know what we need to stop doing, what we need to look at doing, and what we need to keep doing, and revamping that. And that's part of that is looking at that recognition package on how we really celebrate our successes and where we really do well, but also making sure that we're creating an advocacy platform for colleagues that don't feel that we're getting it quite right, that we're giving them a platform to say, okay, how do we get it better? How do we make it work? Why is it not working for you? And that I think the most for me, the most powerful thing about this situation is that this individual's been part of the solution. They've not been secluded. It's not been something that's been, you know, kind of planned without their input. Actually, they've had input, which has actually led to the success of it. And it's amazing that the transformation's been seen post this incident now. And you're saying that the team are, you know, kind of getting on better. You're feeling better. So for me, it's the journey that individuals are going on when they raise concerns, from that initial concern being raised to being part of the solution, then really seeing the foundations being embedded following that, because it shows that commitment and that consistency, and that we're going to do and support you like we've said we're going to do and support you. So yeah, I think that's there's lots of things that we're doing in the trust at the moment to help support colleagues that are speaking up, and you know, kind of how we tackle that, but also how we celebrate it when we get it right.
And what about the support for managers to help them with, you know, dealing with people who are raising concerns with them?
So at the moment, as part of our OD plan, that was essentially commissioned from support with the execs, care groups, people partners, we are relaunching a leadership development program which covers elements of how to have difficult conversations, how to deal with people that are raising concerns. So we're really going to equip those leaders in having those conversations and creating a, you know, kind of a suite of a skill set, so that actually when these issues come to light, managers feel empowered and confident to be able to have those conversations rather than shying away. So at the moment, that's our key focus, is developing that leadership program, which we are aiming to have uploaded onto ESR and live for sessions to be booked on in June. So that's really positive for us.
Fantastic. And just coming back to you, Jo, if somebody feels that they need to speak up, what should they do?
Yeah, so there's lots of options if you need to speak up. And obviously your first point of call should be with your line manager or someone in your department. But sometimes we know that that feels really tricky and difficult. So I work with a team of 55 champions, and anyone is welcome to contact any one of us to have that initial conversation and just, you know, have a bit of time with us to talk through what it is that's happening for them at the moment. And I think this case particularly showed that, you know, I was just kind of facilitating this, but actually we had great support from your head of nursing as well. He was very engaged in the conversations, and also with Gabby as well. So it just really did feel like teamwork. And obviously I just want to say a massive thank you to you for coming here today, but also for speaking up in the first place, because you undoubtedly will have benefited a lot of your colleagues, but also patients as well.
Thank you, Jo. That was really amazing. Very difficult to listen to, but also very important to listen to, and an absolutely brilliant example of the work that you're doing. So thank you for everybody who took part in doing that. I've already got people indicating to speak, so if it's all right with you, I will just go straight on. I've got Kim first and Uzma second, and then Richard. I have to call you Richard too, I think, Richard.
So thank you, and thank you, Jo. I think it's really important, if you consider our earlier conversation as regards the work around our EDI conference and some of the experiences our staff still feel, and how do we get that shared learning, shared experience. Jo and I had a listening event across the trust earlier this week, and we tried different times, different executives joined, but Jo, being the exec speaking out, Freedom to Speak Up champion, I'm also, as well as Adam, one of the Freedom to Speak Up champions. So we attend the meetings as well, which is really important. They ought to be commended. They're 55 really passionate individuals that do this over and above their day job. Jo does an incredible job in supporting them, educating, nurturing, and as this report is testament to, you know, trying to make sure that all voices are heard and that we support. I think sometimes we're all at risk of trying to fix the problem in front of us and nurture the individual. But this case is an absolute prime example where you have to support and change the environment, the situation. Otherwise, you're going to continually have the same events. And how do we get that wider shared learning? And the people promise as well as Joe's role goes a long way in being able to fill that gap. And also Joe and I had a conversation about role modeling. What's our role? And we had that really good board session. Never think that if you're standing somewhere that someone won't see, and the standards of behaviours you've just walked past becomes a standard that people think you will expect. So I've started to call it the 100 hidden eyes theory, that you just don't know who's watching you. So remember to act with your values and your integrity. But thank you, Joe, a real sobering event, but a really good outcome. And how do we share that wider?
Thanks, Kim.
Thank you very much, Kim, and you absolutely do that in all that you do. Uzma.
Again, just mirroring what Kim was saying, that such a powerful story to hear, but especially in terms of what a number of us heard at the EDI conference, and what Joe's report is still stating, that our globally educated nurses are still not feeling like they can raise concerns because they're in fear of reprisal. So these kind of stories will hopefully really encourage those people to speak up, and also reassuring hearing about the leadership program. And I guess my question would be, or the assurance that I'd like to hear is, are those leadership programs mandatory for in these instances where someone has spoken up and felt they'd like to see that action? So it's a question, is that still a optional opt-in to that training?
Thank you, Uzma. Joe, do you want to respond to that?
As far as I know, the leadership training isn't mandated currently, but I think that's a really good, I would say that's a really good suggestion. But please, someone else correct me if it is going to be.
Paul, are you there?
Hi, Mary. Yes, of course I am. I think it's an interesting question. I think we'll look at it. I think there's the culture change piece. We want to take people with us, and there's something about timing and when you do the implementations. We're certainly beefing our induction and our new management guidance, and as Joe and colleagues have said, the training is being rolled out. We haven't mandated it for specific instances at the moment, but it's certainly something I'll take away and I'm happy to consider.
Thank you very much. Richard.
Thank you very much indeed. I mean, we've used the word powerful, and I think that's the adjective that best described it. I also found it very empowering to hear from staff and managers about it. My question was around the mandatory training, and because I noticed in the report that completion by senior staff of the training was behind all staff, and I just wanted to know what support we put in terms of the communications about the training and how we communicate the why this training is important, because there's some links between this work and the results of the staff survey, and it would really show that managers take concerns seriously if this training was completed. So how do we communicate the training, and do we also indicate how long the training will take so managers don't feel overwhelmed and they can allocate the time and space to complete it?
Thank you, Richard. Joe, do you want to come back on that?
Yeah, I think that is really good points. So thank you for that. So I communicate about the mandatory training on induction, but actually we haven't done any specific comms pieces about the mandatory training and why it's important and the different levels that we are expecting all of our staff to do. And I have had some people raise issues about the training, in that if you're a senior leader, you do need to complete all three elements of the training. And I've spoken to the National Guardian's office about this as well. And actually, at the moment, they're not planning to change that. So I think I can have some conversations with the communications team about perhaps doing a news piece on the training and explaining, why it's important, and actually just some approximate times of how long it's going to take people to do it. So I'll take that away as an action, definitely.
Thank you very much, Jo. Ella.
Yeah, I noticed in the report we're asked to consider and look at the trends that are presented for us. And if we look on page 8 of the report, behaviour relationship concerns raised seems to have shown some improvement, you might say, although I think over only 3 touch points is a bit too soon to say a trend. But the bullying and harassment, I note that in 21-22 there were 0 cases. I wondered, is that correct, or is that a change in reporting? And then finally, really what we should be taking from the bullying and harassment numbers. And we've talked before, haven't we, around in this space, if you see an increase, it's not automatically a bad thing that people are coming forward and we're dealing with it. However, I don't think we'd want to be saying, oh, it's good that our bullying and harassment cases are going up. So I wonder if it's almost around, we need a measure around to what are the trends around how well we're doing this and how well we're resolving things for people. So to what extent do people feel they get a satisfactory outcome, rather than just the process of how many cases have been raised?
So the figures are correct. So when so it's not me that decides whether a case is bullying and harassment or, relationships and behaviours. I will, after, a detailed discussion with the person speaking up, it will be about how they feel, and what their case is. And I think, a lot of the cases that are concerning bullying and harassment tend to end up in more formal HR processes. And then obviously, we'll be supported by HR from that point, but I also will then support that person going through. So I guess in answer to your question, no, people aren't always happy with the outcome. But sometimes they are. And actually, I did make a point in the report as well about I am noticing that more of my cases are going through more formal HR processes rather than, what I used to see when sort of the first couple of years of doing this job was more formal, sort of facilitated discussion, getting people together for a coffee, a more relaxed discussion. Often there's lots of different reasons for that. And often people have taken quite a while before they speak up about something because of, the anxiety and how they're feeling about it. So it takes us back to that piece around being able to raise concerns at the very earliest opportunity and have those difficult conversations early on and be encouraged to do that.
Thank you. Thanks very much. Isabel.
Yeah, thank you. Jo, the work you're doing and all your champions is absolutely incredible, and I really commend you. Whilst I was listening to the story and subsequent to that, it occurred to me that, there's a really strong link across from all of the work around our culture and around our organisational development and the leadership development across to our appraisals. And, what I would like to see is a more direct correlation between the skills that managers are able to demonstrate through the way that they approach appraisal. Because for me, appraisal isn't just about objective setting and how have you done and scoring. It's an absolute golden opportunity to build relationship and trust. And it's an absolute opportunity for us to encourage our managers to really encourage their teams to be able to speak up more freely. Because, working within a hierarchy, you're always going to be very aware of that power differential in a management relationship. So I'd like to see how we can improve the quality of our appraisals, never mind the numbers and the ticking, how many have we done and the percentages, but actually, are they meaningful to the people that are undergoing appraisal? I think you said at the beginning, Jo, that, the barriers for speaking up tend to be largely within care groups. So I would hope that any development work that's going on around helping managers to really become skilled not just in having a difficult conversation, but actually being able to listen and listen well would be fundamental to me. So I'd like to see whatever training is taking place through the leadership development programme to be really focused around those things.
Thank you very much, Isabel. I think, Paul, did you want to come back in on that? You suddenly jumped in there.
I did, thank you, if that's okay, Chair. And thank you, Isabel. You've taken the words out of my mouth. I think there's a massive link here with the staff survey feedback, and we might try and triangulate that when we have that session. Certainly out of the staff survey and the work that we're doing with the care groups and linked with this, and one of the priorities in there is going to be a focus on appraisals. And the reason for that is exactly what you've just said, which is around creating that culture means about education and application. And there's something about behaviour breeds behaviour. So the more positive environment we can create, it's almost self-perpetuating. So I absolutely take that point. That's a key focus for us. Thank you.
Thanks, Paul. Adam.
Thank you to Joe and Pete and the colleagues on the recording. That was really powerful and really helpful to hear. I think a couple of people have mentioned about how are we going to share that, and I'm not sure I heard the answer. So Joe, if you could answer on the how we're going to share that recording more widely, please. And then a second question on the paper itself, which probably links with what Ella asked. On page 7, there's a little table that shows our performance on resolved cases in year. I'm just wondering, would there be a benefit in either looking at the trend on that over time for us or comparing us with your network, Joe, of other Freedom to Speak Up Guardians? We're resolving about half the cases completely in the year, I think, from the table. So that's the 2 points, please.
Yeah, I can absolutely look at that with my network of Guardian colleagues. And we are looking at sharing that voice recording with all of our staff. So we're going to do a specific comms piece around that. Had a conversation with Laura about that yesterday, and I will share it, and I have got consent to share it, obviously, as widely as I want to. So that's what I'm planning to do.
That's great. Thanks, Joe.
Thank you, Rob, and then probably Steve could be the last speaker, if that's okay. Rob.
Joe's response to Ella answered my question, Mary. Thank you.
Lovely, thank you. Steve.
Just to segue back to the previous item, Joe, we had a really good discussion with Sarah on the Guardian of Safe Working Hours annual report, and we're just starting to get into whether there's anything further we can do in terms of correlation, triangulation, alignment from a FTSE perspective with our Guardian of Safe Working Hours safe working approach. So really a question for you, Joe, as to whether there's anything further we can do to help support and triangulate on that. And I also just wonder, Alistair, you and I were at a very useful half day with quite a number of our junior doctors, talking to them with them around compassionate leadership culture and engagement, and just whether there's anything that falls out of that might help support this as well.
Yeah, I'd be really happy to have a conversation with Sarah about what more I can do to reach out to doctors. I do a specific induction for our new doctors with our GMC regional lead about raising concerns. And I think that's all very well and good, isn't it? That it's I heard Sarah talking about, she talks about things on induction, but actually we need to keep the message going. So I'll have a conversation with Sarah about, what might be valuable and how else we can tap in. And I would love to have a champion who was a doctor, because I don't have one. So that would be really good as well. So Sarah, I'll send you an email. We can get together and discuss.
Thank you very much, and thank you, Richard, for your point in the chat, which I won't go completely over, but for the benefit of people who can't see the chat, Richard's making some suggestions as how we add some population context to the numerical data, referring particularly to page 10. So I think if, Joe, you're happy to take that comment in the chat as well, that would be really helpful. Is there any more Joe, can I just thank you for, again, a really, really helpful report. As you know, and some people know, the board had a really good development session on freedom to speak up about a month ago, I think, and there was good engagement. So I've really valued what you've done today. Adam, thank you for your input too. And perhaps we could convey thanks to the people who took part in making the recording. Very important. And I'm very pleased to hear that you are intending to use that. I think it will be very powerful, as some board members have said. So if we could then agree that we're noting the issues identified and that we're noting the feedback given from colleagues. And then thirdly, you're taking away a couple of suggestions from the meeting about how further to develop the work that you do. If everybody could do that in the chat, I'd be grateful. Thank you. And Joe, again, you're very welcome to stay, but you and Sarah can both go if you have more important things to do. Thank you for being with us today. Thank you. Bringing us to the time when I can save my voice and pass it over to Robin. We're on to our journey of improvement and we are looking at the integrated performance report. Perhaps, Robin, just before bringing you in, to note again that each of our committees does cover in some detail their aspects of the integrated performance report. So if I could ask you to highlight those areas you would like us to give our attention to. Thank you, Rob.
Thank you, Mary. A number of topics were also covered in Steve's update as well, of course. So I'll do a very quick whistle stop from an operational perspective. We'll just highlight that the system oversight framework measures, we call them SOF. We've moved to 12 red, 1 amber and 7 green. And that's a deterioration on previous months, actually. So just to highlight that to colleagues. We touched on the 4-hour performance in Steve's update as well, but to note that our system performance is above the 76% standard for all types. Our ED performance, so what's known as type 1 performance, is still below where we would want it to be, and although marginally improving at 42.8%, it's a very significant focus for us on doing more actions with regards to the turnaround time of patients in the emergency department. And linking to your point around the committees, Mary, we're very cognizant of a risk on our risk register relating to how crowded the emergency department is. And part of that are our actions to reduce the crowding in the department. And in doing that, we will see that 4-hour performance for what we call type 1 further improving. So the flow programme remains in place. I think the things to highlight are that we've changed our bed meetings now to site safety meetings, as I mentioned earlier, around our really encouraging people to feel it's right and safe to advocate for our patients and drive those ripples of positivity. I need to highlight the delayed discharges improved to 112, which really has supported the improvements that we're starting to see in the emergency department. And through April, those improvements in delayed discharges have also continue to see improvement, and we've seen the subsequent improvements in our performance as a result. Steve covered the elective and cancer performance in his update, but just to give the hard numbers for colleagues, so our 78-week waits reduced to 125 for March, and our 65 waits reduced to 599. Just to remind colleagues that our trajectory in the operating plan at this point is to get to 270 patients over 65 weeks by September 24, but we're doing further work to see if we can go further on that. So we're definitely on a improving trajectory now with those long waits in orthopaedics, but much more still to do. I'll read out the cancer performance because it's important and we do keep a focus on that. So our 28-day faster diagnosis is at 81.5% against the 75% target. Our 31-day decision to treat performance is 95.6%, just missing the 96% target. Our 62-day performance declined marginally from 84.5% in January to 80.9% in February, but that's still above our adjusted trajectory. And just to note, for March, the target was 85%, so we're just missing that target there. And I will just then also note that on stroke, we've seen an improvement for the second month now on the admission to the unit within 4 hours, but only 2 months is not statistically significant, and we are still far below the performance where we'd like to be, which is 90%, with a reported performance of 4 to 7%. The work that we're doing for 4-hour delivery in ED in totality will also support that significant stroke indicator. But you'll note from the report the remaining indicators in stroke that we monitor are above the target lines or almost at them, but that's the one that we're particularly watching. I will therefore then just do a quick run round, because I can see her first. I'm going to go, Kim, is there anything you'd like to add from a nursing and quality perspective?
Yep, just one thing that we haven't touched on. I'm sure everyone's noted, if we look at duty of candour, it was quite low, and it's 76% today. I think it's really important, and we did speak about this at the Quality Assurance Committee, that duty of candour is 4 steps. The first step being the initial apology, and we work our way through. Of the 76%, the outstanding cases will be spoken about at the Incident Learning Review Group in detail today, as they would be. But to note, it's no surprise that those small number of cases, which I think equate to 6, are either joint, so they're more than one organisation, or in a coronial or other wider investigation. But both RCHT and CFT are looking at how we better report this across both organisations as regards a step change. So I think we need to mention that. Thank you.
Thank you, Kim. If I go across to Alistair, if there's anything you want to add from a CMO perspective?
From my point of view, I don't think there is. We talked about mortality earlier on in learning from death, so I'll leave it for interest of time.
Thank you, Alistair. And last but by no means least, Paul, from an organisational development perspective.
Thank you, Robin. And yeah, I just wanted to pick up a general point that, generally speaking, the HR metrics have improved smallly but incrementally over the past few months. And I do think that's triangulated across to some of the improvements we've seen elsewhere in our culture. But particularly, I wanted to pick up on the vacancy rate, which has fallen again to 8.6%, and that's now the best performance in 22 months. But that does hide the fact we still have a 13% vacancy rate with nursing. But I'm pleased to say we've got 50 internationally educated nurses going through our OSCEs at the moment. They're due to land with us in the next few weeks, and we're hoping that will again improve our position and improve our substantive fill for nursing colleagues. The one area of concern still remains sickness, and more that sickness has come down, which is good, and it follows a seasonal pattern. We tend to see that as spring comes, but we're still concerned about the percentage of stress cases that are in there. And that's certainly a priority for our occupational health, and it's part of the training that we're bringing in for managers as well, to recognise symptoms of stress in both themselves and colleagues, to help us deal with that. And we're moving into more of a prevention area with health and wellbeing as part of a mix of support for staff. Those are key points I wanted to make. Thank you.
Therefore, Mary, I'll hand the floor back to you.
Thanks ever so much, Rob, and thank you for taking us through that. I do think, Paul, just to comment on the recruitment, because I had a question about that. I think it's really to be noted, and your team to be congratulated for the changes that you're making. It's really important, and it's not an easy time. My question was around the last few times I've been in and around the trust sites. I've been aware of how many of our international nurse colleagues are in the different uniforms, which indicate that they haven't done the full conversion or whatever it is. Sorry, I don't know. But I was just wondering, how do we help our colleagues make those steps? Kim, probably you know better than Paul, but I was just really struck by how many colleagues are in that different coloured uniform.
Yeah, so there's quite a wide team that do not just that pastoral support, but support to be able to pass the what's called an OSCE, but it's an exam of competency. I think it's been widely acknowledged that the 18.5 hours that were initially nationally thought to be the correct time has proved a challenge. This is no reflection on very skilled individuals. Oftenly they are not newly qualified staff, but it's that change of culture, environment. You know, some of our legislation around safeguarding and other things that has required additional attention. So it has taken about, on an average, 22.5 weeks, not 18.5 for acute. As a senior team, we're acutely aware of this and working with the learning and development team to see what additional support we can put in. And we do frequent check-ins, especially if someone has failed, for example. You know, what additional support do we need to be able to put in and offer as well is key critical. But it's testament as well, Mari, that you're seeing the numbers and the differences, because that community is ever widening. I think across RCHT now we have over 200 colleagues that have joined us from our globally educated workforce, and that's really important.
Thank you very much, Kim. And I don't want to prolong it, but I think it is all joined up, isn't it? What we were just saying about culture, what we were just saying about freedom to speak up, what we're saying about current colleagues, because those to whom I've spoken, I think, were expressing that they are lesser people than their colleagues who've got the ESCI, and actually in their own countries of origin they've been senior practicing in their own right. So I think all of these things are linked, aren't they? And the more we can focus on helping that, the better.
Yeah, and the more parity we can give. So we work, having a dual role, we work closely across RCHT and CFT to make sure, having trained overseas myself and coming back, sometimes you choose an area where you think you know what you're coming into, but it might not. When you land, you think, actually I'm more suited to that ward environment or that discipline. So we also encourage that if you do want to move specialty, you're able to do that without being thought less of. And we do a lot of work with Joe and myself. We attend where people are first inducted in and explain. We've also asked some of our more colleagues who've been with us longer and who have now been promoted to come and talk to our new recruits, to say this is the art of the possible, and if you see a vacancy, ask, inquire. Everyone has equal rights. So we're doing a lot of work with our more established nurses now to do some role modelling and to be able to sometimes reach through the cultural barriers as well to give that authenticity.
Thank you very much, Kim. Ian, thank you for your patience. I'm sorry I dived in there with some questions.
Absolutely fine, no problem. So yeah, thank you, Robin. I just wanted to go back to you quite rightly highlighted the 20 single oversight framework metrics and the fact that we read on 12 of them. But I wouldn't want us to lose, when you look particularly at the RTT weights and the graphics, the significant improvement over the course of the year, and recognising all the hard work of your teams, Alice's teams, and broader. And as Steve's touched on, the ambulance performance in recent weeks. So whilst absolutely they're red, I think there's just something about us making sure that we reflect on the progress that we're making as an organisation against some of those ones, not taking away from the fact that still has a lot of patients waiting a long time for their treatment, which is not a place that any of us would want to be.
Thank you, Ian. Go on, Rob.
I think, Ian, you're right. Our IPR actually picks up that phrase I've coined from a colleague, which is the ripples of positivity. We are absolutely seeing a number of our metrics moving in the right direction. They're still red from where we want them to be, but the graphs are beginning to head in that right direction, and that's the energy that we want to try and build on. And thank you for the RTT piece, the referral to treatment, for colleagues watching. If you think we initially forecast in 22 that we would have had by March just gone 4,000 patients waiting over 52 weeks, we came in just under 2,000, and that's a really material change and improvement that our teams have delivered from what was if we hadn't have enacted the action plans that we did. an additional 2,000 patients have effectively been treated through that work, which is really significant. So thank you.
It is, Rob, you're right. And that number, I haven't quite got it in front of me now, but going down from 760 something to 560 something, that's a huge, it's just not to be underestimated, actually. It's still a very large number outstanding, but it is huge. Ella.
Yeah, I just wanted to very quickly update as well on a piece of progress we've made around our methodology on improvement. So you'll note in the report we use, wherever available, statistical process control charts, so that we are aiming to focus our discussions around things where we've seen a significant moment, where something statistically significant has happened in terms of either deterioration or improvement. And previously we haven't had that available at our care group level. We do now, so our information services colleagues have done a fantastic piece of work to have, so we now have over 600 statistical process control, sorry, I always get that the wrong way around, charts available to care group leadership teams, so they can really drill down and we can focus our performance reviews on the things that are significant and where we can see, rather than saying up a bit, down a bit each month, we can say, look, there's a sustained improvement there, or hang on, there's something significant deterioration wise going on, let's talk about it more. So I think it's a really big step forward for us in terms of our maturity on how we do improvement. I just wanted to flag that to board.
Thank you, Ella, that's helpful. Other comments on the integrated performance report? In which case, thank you very much for the work that goes into preparing that, and to you, Rob, for presenting it. So if we could please note the report and move on to our finance performance assurance report. And again, this is a report from the committee that, again, one of the bigger committees that does heavy lifting for our board in terms of our finance and performance. So if I could invite you, Richard, please, to present your report.
Yep, certainly, Chair. Thank you very much. And firstly, just to thank Lindsay for all of the work in such a fulsome report. It does highlight all the work we've been doing, and thank you for our colleagues across the board, and particularly in the committee that do the work that takes us through that agenda. In the interest of time, I'll just ask the board really to note the decisions that have been taken on behalf of the board at Finance and Performance Committee, and those items that have been discussed for assurance and scrutiny, and where we've given partial scrutiny, I hope, partial assurance, sorry, I hope that the report makes that clear, but happy to take any questions on those items. Other things just to raise on behalf of the committee, there are a number of items escalated. As you'll see from the report, some of those were in the March meeting because this covers 2 months, and those have already been raised back into the April board. So I'll focus on those from the April 2024 meeting. And most of these are for the board's awareness rather than the board to do anything. Really, one of the things that's coming out of there is we did consider cash flow as part of the operational financial plan going forward. As people in the board will know, at our extraordinary board, we saw a revised version of that, which is addressed to a large part that cash flow, but we still note that that's something that we should keep our eye on, and FPC, Finance Performance Committee, will keep close scrutiny on that as we go through the year. We also wanted to just note, and it perhaps links back to what we said about the Green Plan, that in looking at a financial and operational plan in 1 year and the benefits that accrue in that year, we just wanted to make sure that the board kept its eye on the investments that are required in year that will have realisation benefits in a longer timescale, because it's very easy to get sucked into doing the in-year balance sheet when actually some of those benefits realisation will accrue in the next several years. And I think the Green Plan highlights some of that activity. We asked for more specific escalation, really, that may need further escalation at some point, is just for greater clarity from our system colleagues, particularly the ICB, around the governance and control of our system cost improvement programmes, a number of which we are contributors to and collaborate within, but we also have dependencies, and we're still a little bit of lack of clarity around the capacity for control at a system level. The other thing that I think was useful to raise, and we'll come to it in another discussion really, is as we've just taken the IPR, we wondered, as we looked at the annual review of the integrated performance Report. Sorry. This is why we use acronyms. The Integrated Performance Report. Whether more could be made of the metrics that come out of that into our individual board papers, so that we keep the focus on the IPR rather than as just an individual piece, but use it as the living document that informs our decision making throughout our papers. So that's for a recommendation for a discussion in board at some point. I think that covers everything in the report, other than to say, as Ian will cover in the month 12 report in a moment or two, I think I'd just like to extend the thanks of Finance and Performance Committee to colleagues everywhere in the Trust, because we look at a balance sheet which is done by our finance teams, but it's the product of all of the work that's been done across the Trust over the year. The fact that we're able to report back a break-even position in revenue, and the fact that that contributes to a system break-even position across our revenue, has massive implications actually for the Trust, and Ian will touch on those in terms of the benefits that accrue from that, not just because it's our statutory obligation, but also because we've got some benefits that flow out of that, of historical debt and access to more capital in the future. And I'd also just like to note in the capital report around month 12 that actually the ability for the Trust to land to within £50,000 on a £45 million capital budget is akin to putting your aeroplane onto the head of a pin. And so again, thank you to everyone who's made, and that's been a very exacting and challenging year, and we've had to make a number of, I say we, the Trust has had to make a number of changes to its portfolio of capital spend to achieve that and to ensure that we delivered all that we possibly could for the Trust in that year. So big thanks to everyone that's been involved in that. Happy to take any questions.
Very much, Richard. That's very assuring to hear. Have colleagues got questions on that report? Yes, Steve.
Not a question, just a brief comment on the system-wide cost improvement schemes. Richard, I think it's a very helpful comment, and it was also something that was covered at the Integrated Care Board meeting this week, with a determination from ICB executive colleagues and the wider board to ensure that there is that mechanism of oversight escalation that ICB colleagues and individual organisations can have sight of. So I think there's an absolute alignment from our ICB colleagues on the importance of that.
Thank you, Steve. No more on that report. You've done too well, Richard. You've covered the points beautifully. Thank you. So if we come to 14.1 then, please, Ian. Our month 12 revenue financial report, please.
Thank you, Chair. And thank you, Richard, firstly, for your comments, part of that feedback on the assurance from the committee. So for members of the public watching and for colleagues, this represents our final report of the 23-24 financial year. And that's now subject to the external audit process, which is commenced and concludes in mid-June. Richard's already taken the headlines, but the end of year position was a £100,000 surplus, and that's in the context of a spend of £672 million. So as you say, a really significant achievement. It meets our break-even plan that we set as a board at the start of the year, and at the time we set that, we acknowledged the level of challenge within that. We've also had various things thrown at us through the year, including significant periods of industrial action, which we were told not to plan for, and which obviously will continue as a risk into the new financial year. It does mean we meet our statutory duty as an organisation to achieve break-even and to live within our resources. And in that context, I think that's something we should kind of just take a moment to reflect on. Richard's alluded to the fact that the overall system has achieved that break-even position as well. So whilst we're statutorily responsible for our performance, we are also required as part of our regulation by NHS England to make sure that as a system with our partners, we also achieve break-even at that level. And that was achieved collectively with a £180,000 surplus for the three organisations together. So two of the key benefits that arise from that, just to play out, that are in the report, is the £115 million of historic ICB, so Integrated Care Board, debt is written off. And what that means in practical terms is that that would have at some point in future years been deducted from the allocation of funding the system gets from NHS England and from government. So when the integrated care boards were established, that was one of the asks of them and one of the opportunities created, that if they could achieve break even in their first 2 years of operation, that would be written off. So that's a really positive step forward. The other is a share of a significant capital incentive funding. So there's two elements to that. One element of it relates to deliver the financial plan. And so we've indicatively been advised that as a system we'll receive £1.6 million more capital funding to help in 24-25, which will come back to board as part of the reprioritised capital plan that we'll receive at next month's meeting. A couple of other elements just to quickly pull out of the report. So our agency spend was down slightly in March at 1.5 million. That still sits above the cap that we're set and the target that we're set, and we see that in the IPR as one of the metrics that's currently sat at red. It has seen a continuing decrease. So when you look quarter on quarter, our fourth quarter of the year is a marked improvement. We need to maintain that improvement to get to a point by July where we can hit the 3.2% target that's in place for next year. And that's around about £1 million a month, to give you an idea of the scale of movement. We touched on some of the elective elements of the IPR a moment ago, but the elective recovery income, so this is the variable income that we get attributed to that that patient cohort that we've managed to treat, that we've referenced. That's a really good operational outcome, but it also has a financial benefit to supporting the additional costs of delivering that activity. So 10.7 million was achieved across the total of the year in terms of the additional that we were able to deliver from that. The SIP programme, so again, we set a challenging £28.1 million SIP target. You'll see in the report that that's been achieved with 11.6 million of that being achieved recurrently, which is around 41%. So that's a really good position. There is still further work. I just need to clarify, there is still further work with some of the recurrent elements of that to fully transact it into the budgets for the, or out of the budget, sorry, for the start of 24-25, and that's work that's going on actively at the moment. And then just to finish on, the positive position on cash is in the report. So we regularly report through the Finance Performance Committee and get a good level of scrutiny on our cash position. Our year-end cash position was £6.8 million favourable against the plan, at just under £17 million overall. And I think finally the other good discussion we've been having at the committee is our run rate of expenditure and how that sits at the end of this financial year as we move into next year. And some of that was covered in the extraordinary board paper when we talked about the 24-25 operating plan. So I'll pause there for any questions or comments.
Thank you, and again, very comprehensive and helpful report. Colleagues, are there questions for Ian?
I'd just be interested to hear more about your controls and agencies, and particularly the actions taken by the resource panel, and how you've gone about tackling agency spend.
Yeah, so I think the first thing I'd say is that is by no means is that anything particularly to do with me. There's a lot of work from a lot of people, and Paul might also want to comment because his team and the workforce efficiencies team have done a lot of the really good work on that. So essentially, Richard, that forms two key strands. One is looking at the demand for where we need to use those agency staff. So they clearly have a key important role in helping the functioning of our organisation. But what we're looking at is how we can maximise the opportunity to use our own staff or our bank staff in place of the slightly more expensive agency. So one way we do that now is a really simple change that I heard about at the Workforce Efficiency Update yesterday, was that we leave agency shifts open to bank staff right up until the point that the shift commences, essentially. So that if we can find, if a bank member of staff suddenly is available, they can take that. So there's an element of it around demand and looking at where the agency is being used. The other element is work about reducing the rates we pay, so working collaboratively across CFT, Cornwall Foundation Partnership Trust, and RCHT, but also across the South West. So there is regional work being done on both nursing and medic rates that are paid to agencies, because clearly what we need to do is work in unison with our organisations in health across the region to make sure that if one is paying more, that doesn't then pull the workforce from one place to another. So there's quite a lot, but Paul may wish to add more. I don't know if that answers your question.
No, certainly does. I just wanted to know, are you putting extra controls on the use of agency staff so that I get fully about using bank instead of agency? Are you tightening the controls so people don't automatically use agency staff?
Yes, so they go through a process within Kim's team in terms of sign-off, and also for expensive agencies over the caps that are set by NHS England. There's an escalation through myself as CFO, Robin as Chief Operating Officer, and then Steve as well, some examples where it's applicable as Chief Executive.
Was that what you were going to say, or? Yes.
Yeah, for nursing, midwifery and AHPs, all agency gets signed off by one of my senior team, but the huge focus is on substantive recruitment, whether that be globally educated, grow our own, return to practice. We're trying to absolutely fill our vacancies, and then secondly, it is about using bank as a preference and agency as a last resort, and there's very, very strong controls, but supportive controls as well, because at the end of the day, we can't leave wards at risk. So there's always that check, control, balance, which also includes 2 real-time redeployment staff meetings each day across the 3 hospital sites.
Thank you very much, Kim. Thanks, Richard, for your question. Adam.
Thank you, Mary, Richard and Ian for the finance papers. I'm working virtually, so I'm trying to read the physical room, and I maybe haven't read it as well as perhaps I could, but I just wanted to emphasise something that Richard and Ian both mentioned around the write-off of historic debt by being able to break even, and the write-off of £115 million of historic debt relating to the clinical commissioning group is fantastic, and I couldn't quite feel the excitement in the room, and so I'm just repeating it. So and that enables the whole Cornwall system to start with the clean slate, which is brilliant, and thanks to everybody across the trust that's enabled that to happen by breaking even on the financial year. I know it's been said, but I wanted to say it again.
I think you were dead right to say it, Adam. Thank you. And I think there may be a slight pre-lunch flop in the room that you just raised beautifully. Absolutely right. And I was actually going to say, Ian, I remember 2 or 3 months ago commenting on that wonderful paragraph you'd put in one of your reports about what would be the benefits of achieving this, and you'd done about 5 lines, and it was spot on. So thank you, Adam, for raising that. Steve.
Well, just to build on that, it is the case that not every trust and not every system has been able to deliver a break-even financial position. That the environment in which we've achieved that has been an exceptionally challenging one, and as colleagues have already said, that aside from the statutory requirements that we have to deliver that the patient benefits are significant. And should we not have achieved that, the potential for, over a period of time, £115 million of historical clinical commissioning debt to be removed from the system, it could have had quite catastrophic impacts on primary care, on Cornwall Partnerships NHS Foundation Trust, as well as on us as an acute trust. So preventing that is a significant step, and the benefits that Ian just outlined in terms of additional capital investment that we would not otherwise have received, I'm sure will make a further contribution to improving care. So it is a really significant achievement. Well done.
Thank you. So then if we come on to 14.2, and then we'll come back to noting all the papers. Ian.
So similarly, the capital position for the year end is just a £36,000 underspend, so 0.1% of our budget. And you'll see in the report that partly the way we've managed that to land so successfully is by the really good work of the medical equipment team and some of the medical equipment purchases. So that's one of those areas that you can kind of quite rapidly deploy where you have slippage on bigger kind of estate-based projects. So my thanks to that team amongst all of the teams for the work that they've done in helping manage, as Richard described, a programme that's had multiple reprioritisations during the year to make sure we get the benefit. And I think that's the bit I really wanted to focus on is this. In this report, we've spent £44.4 million of capital funding across the organisation, and to give colleagues and members of the public an idea, that's on environmental improvements in terms of the look and feel of the buildings when you walk round, which we know some of them are in quite a sorry and tired state, but those improvements, really do make a difference. The equipment, the ability and access to equipment that our colleagues and our patients have, and some of the major developments and things that people don't see that sit behind the scenes. So some of our, RE health related schemes around cyber security and keeping all of our systems safe is really important work that you wouldn't see and feel in quite the same way as some of the other ones, but often can often go overlooked. And then you'll see in the report some of the public dividend capital. So this is the central funding that we get from government for particular major schemes, a significant spend across our e-care programme, which is our replacement patient administration system, our Women's and Children's Hospital, which is well known about in terms of the development of that, and our other peripheral sites development, example of West Cornwall and the work that's commenced down there. So that's a really positive piece, but I do need to balance that with a little bit of caution in that some of the impact of slippage on schemes means that there is a carry forward, as you'll see in the report, of 2.3 million of cost impact into next year's capital programme. So whilst we celebrate, and it's right that we do that, we now turn our attentions, as you'd expect, to how we manage that and how we make that work. And the team are doing a lot of work, and Brian Johnson, the new Estates and Facilities Director, is also heavily involved now with understanding how we make sure we prioritise and how we identify slippage and learn from slippage on projects. So we're working in quite a complicated construction environment, for example, and some of the supply chain issues, but learning from that so that we can even better manage our process through the year in terms of slippage and impact. So the impact of those schemes moving next year will come as part of the board's updated capital plan. So we've already approved a capital plan as a board back in January to allow us to get on from the 1st of April with that work. We'll be bringing back a revision to that to the May board. So again, pause there and open for questions.
Thank you. Thank you very much. Are there questions for Ian? Richard?
Not a question, just an observation, again, to try and give some reassurance and hopefully assurance in the future. Ian's touched upon the public dividend capital element of our capital expenditure. That comes with a wonderfully named public dividend capital dividend, which means you've got to pay some of that back, if not all of it back, at a percentage rate. So that one thing that F and PC, Finance Performance Committee, are exercised by generally is, what revenue pressure do we continue to put on in future years by taking on the PDC? It's the right thing to do. We think we've got the balance right, but for board to be assured, I think, or reassured at this moment, that that's in the eye line of Finance and Performance Committee to make sure we don't overstretch on the revenue pressures associated with capital income.
Thank you, Richard. Other comments or thoughts? So then if I could just comment on how amazing it is, given the amounts of funding we're talking about, that we do come in, and reiterate Richard's congratulations to your team. And I like the point that you made about is everybody does that. It's not just your team, but it's good leadership from your team. So thank you for that. Could I then ask us please to note item 14.1, Item 14.1, I'm going to add a bit, Lindsay, if I might, that we note the year-end trust financial position and welcome the write-off of the historical debt and the benefits that will bring. So that's 14.1 and 14.2 if we could note. Colleagues, please, if you would note that in the chat for me, that would be helpful. Which brings us to 14.3 at an amazingly early time, which is a starred item. I haven't been notified of any questions for that item. So I think we can then, oh, not quite as amazing time as I thought, but never mind. We can then move to a lunch break. And could I suggest that we do take 30 minutes? I think we need it. We've still got a long afternoon to go. So given it's 12:43, could we please come back at 1:13? And I'll hold you to those 2 minutes. Thank you, everybody. Thank you, those online. See you after lunch. Okay, welcome back, everybody. I hope everyone's had a chance to have a bit of a break and a bit of lunch. And those of us on the Teams, I'm so sorry you didn't get a sandwich, but I'm even more sorry you didn't get any of the cake Isabel brought in. So
It'll be distributed.
It can be distributed, righto. Those nice little boxes you get at weddings. Right, thank you everybody for being back on time, beautifully. We're now at the valued and supported people section of our agenda. And our first item is 15. And I'm going to invite you, Adam, please, as the chair of the People and Culture Committee, to present the assurance report.
Okay, thank you. If I can check people can hear me again, okay. Great, thank you. So yes, we're on to item 15 on the agenda, which in the pack is page 297. And I will assume colleagues have read the paper, so I won't go through it in detail, but just to highlight some positives and bring some issues to the attention of the board, please. So lots of crossover and synergy with what we've talked about already today, as you would expect. There's been some really good work and really good progress around the organisational development programme, which is lovely to see and linked really nicely with the FTSE recording that we were watching earlier, actually. And there has been some really positive outcomes from the staff survey results, which we'll go into in more detail in the next item on our agenda, and where there are areas highlighted from the staff survey that we need to address and improve, there's an action planning process underway. And the other area to highlight from the positive area to highlight from the work that we've done at the People and Culture Committee is there's some really good work continuing around improving our HR systems, which will improve the data we can extract from our systems, make it more efficient for managers to use the systems and make it easier for everybody to use our HR systems, which is really great to see. So thanks to everybody for all of that really good work. There's two key issues I wanted to flag for the attention of the board from the committee. They are on page 297 in the pack, both of which we have brought to the board before. They are challenges that we're working hard to address, but it felt appropriate to bring them still to the board because they're not in the place we would like to see them in for the trust as a whole. So the first one is around mandatory and essential training. And we absolutely recognise really good work in place, and we're seeing slow and steady improvement in the proportion of our staff that have completed the mandatory and statutory training that they're expected to have completed. But it is slow and steady improvement. We're not seeing that step change. And we talked about the integrated performance report. It's on page 232 in our pack today. That you can see and track that slow and steady improvement, which is great that we're seeing slow and steady improvement, but it is slow and steady, and it's what else could we do to achieve a step change. And the other area to highlight is ongoing concern that we've raised before around stress-related absence in our workforce, and recognising we're doing lots to try and address that. And we've done some excellent work to look at what the issues are in our occupational health team, and we have an action plan in place to address those issues over time. but felt appropriate to bring that to the attention of the board again. And I'll probably stop there, Mary, and happy to take any questions.
Yeah, that's very helpful, Adam. Thank you so much. And it's a nice full report, isn't it? Which again shows just how much work goes on that committee. So I will ask colleagues if there are any questions for you, and then I'm going to come back to your escalated items. So colleagues, are there any questions for Adam on his report? Isabel.
Thank you. It was in relation to the Statman training, Adam. Unsurprisingly, I think I've mentioned this so many times since I became a non-exec director, and completely agree with the concern about the slow progress towards getting us to where we need to be. I think the clue is in the heading, really, isn't it, in terms of statutory and mandatory. And we haven't met that for a very long time. And I wonder, I think I possibly raised it at a committee meeting, but whether any progress has been made to trying to risk assess where we're falling short around our Statman training, and in somehow benchmark that against quality priorities, because I think there's some areas where I think in discussion with Kim, certainly, where we've thought, well, what's going to provide the greatest risk to us around our patient safety and quality and our staff safety and quality if we're not complying with the 100% Statman training.
Thank you, Isabel. I wonder whether, Paul, you would be able to respond to either of those points. You were at the committee, I know. And then maybe I'll come to Kim.
Thanks, Chair. If I can share the response with Kim in terms of the quality side. I think from the learning we've had so far, I mean, it is frustratingly slow progress. I'm pleased to say we are making small improvement. We know when we looked into some of the issues that are behind that, some of that you can correlate that sometimes with staffing levels and operational pressures, but there's also a link we've acknowledged to the digital solution we need. So access to ESR in its current state can be clunky. So as part of the workforce transformation programme, there is a solution in that business plan to look at to improve and bring it really up to speed digitally for the age we're in. So we're looking at a digital solution to the access issues. And back to Isabel's point about the clues in the title, we also constant review what is essential and mandatory. And we've tried to link some experiential learning, some additional learning to be counted as that where it's appropriate, and make that easier to access, and also shorten some of our sessions, and then target some sessions to areas that have struggled to meet that. So that's some of the work we've done to try and improve. And I think the board are right to not be assured with the fact we've not made that significant step change yet to get that momentum forward to the target. I think I do see correlation across in terms of patient safety and outcomes from issues, and we always look at the background links between where we've got lower levels of essential mandatory training. But I might just look to Kim for any additional comments on that, because I can sort of take us that far, but I probably don't know all the correlation with the quality issues. Kim, if you could assist me with that.
Yeah, sure. Yeah.
Sorry, Kim, I was just going to say, perhaps before you do come in, there is some progress. Paul, are you able to talk to us about what are the things that are working, and is it just a question of we need to do more of those? So we have got some progress. What is already working?
What's working is there has been additional focus in care groups, and I'm pleased to say they've really responded well to that from us. The areas where it's worked well is to look at where on-the-job training can count, and where learning at the workplace can also count towards the uptake of Statman training. And again, we've looked at adapting the sessions. So we've done some one-to-one sessions. We've moved some of the work back online. We've looked at a better way of accessing ESR within its current constraints. So we've done lots of things to sort of make life easier. I think the bit that's still missing is we've not achieved a significant step change to make the move that the board needs to see to be assured. And I think that's the bit, the digital solution, which will be something probably on a smartphone that everybody uses now, or some of the system you can access really easily that sits on top of ESR to make that connectivity so much easier. Because a lot of the issues we do here, and I go to care group performance reviews, and I do talk to both managers and staff about this, is that sometimes the link with ESR can be a little bit difficult when you're time poor. You just need that to work slickly, and that's the bit we're really focusing on at the moment.
Okay, thanks, Paul. Sorry to cut across you, Kim.
No, not at all. So I suppose I say this at committee as well. It's we've I think across the board now nationally they're looking at mandatory, regulatory or statutory training because the list is never ending. Then you've got your specialty training, haven't you? So that's like for ED, maternity, critical care. They have additional training which is a core part, especially since Ockenden as well, that's closely monitored. So I welcome, and we're going to do it across RCHT and CFT to see what does that look like. You've then, as Paul says, you've got that balancing act between the data that you're looking at and what does it say about quality and safety. So we know, for example, when we had our focus on safeguarding, and safeguarding is absolutely statutory and regulatory, and it got to the stage where I personally wrote out to everyone who was non-compliant. My inbox nearly crashed, but actually we've then found that some people had trained but it hadn't been updated. We found some thought they were up to date with their training but had only done level 1 and they should have done level 1 and 2. So I think where Paul and we've got to work collectively is making sure once we've cleansed it, it's accurate, it's reflected of the current situation, because that is our data platform that we are judged on. We've then got to do that unpicking of what is everyone's level and is it right for that person. And then secondly, Isabel, it isn't just about numbers, isn't it? So but in our rotas, for example, we've got competencies that are required for each shift. So it's making sure that you've got the right competency against the shift as well as the right numbers. But that's where we can start triangulating as we get more sophisticated, and you can see, such as maternity, where that ESR cleanse has been done correctly, we can now start to target where those gaps are confidently, and it reads across to the Aspire. So don't forget our accreditation program. You start to get a better picture, but we've got a lot of work still to do on that.
Thank you very much, Kim. That is helpful. I'm going to bring Steve in there, if I may.
Yeah, thank you. Thank you for the escalation as well. Paul, appreciating the update that you've given, which I think is helpful. It might be useful if we could see that back at board in terms of what is that telling us? If you undertake a review of statutory and mandatory training, is that assuring us that every element of statutory and mandatory training is statutory or mandatory? Is there part of that review about what is the necessary frequency of those training programs so that we are providing the most appropriate training at the most appropriate timeline? You've already touched on the opportunities to improve how that's accessed through digital means and others. So how accessible is the statutory mandatory training? And as Kim's just touched on there, are we assured that it's accurately recorded? So I think if we could have those things back to us, either at board or through the People in OD committee, that I think we'd need to see that giving us a basis for what's our trajectory for improvement going forward, and how do we move from the slow and steady improvements to a more rapid improvement. And if that requires a prioritisation within statutory mandatory training to reflect the risk range that we're seeing across the trust, then that might be appropriate to see that as well. And then, Mary and Adam, that might help us be clear about which bits do we expect the board to oversee and which bits do we expect the People in Organisation Development, People and Culture Committee to oversee, and which bits do we expect to be overseen through performance reviews or from an executive perspective.
Yeah, I think that is really helpful. Adam, I think, would you be happy with, I'm going to come on to the stress-related absence in a minute. How does that sound for the statutory and mandatory? Oh, hang on a minute, Adam, sorry. Alistair first.
Yeah, just to confirm though, that I think when we do this, I think there was a letter that came out from Amanda Pritchard and Steve Powis just last week, which was entitled Improving the Working Lives of Doctors in Training, which had a number of recommendations in there about statutory and mandatory training, including aligning to the latest core skills training framework by the end of June 24. So whatever we do, we need to think about how we align with this particular letter, which talks about using e-learning for health, digital staff passports and things, which allows people to move across boundaries with the same mandatory training. So I think take that into account when we're doing this.
Include that, yeah. Thank you, Alistair. Adam, does that feel like a way forward?
It does. I'm very happy with what Steve in particular outlined. So if perhaps putting Lindsay and Steve on the spot, if that could be read back as an additional recommendation for us, that would be really helpful. And I would suggest that we take that through the People and Culture Committee first, perhaps, and then on to board at the next available opportunity, and look to Paul as to when we can have that report ready.
Thank you. Kelvin, I was going to bring you in, so perfect.
Thank you. Probably helpful to set the discussion into a wider national context. We're in effect in a very extended transition because for the public, ESR, the electronic staff record, is a nationally provided system. It's provided by the NHS Business Services Authority. They are running a procurement exercise to replace ESR with a more modern solution, which is what everybody would hope. But because it is such a large system, the NHS is one of the largest employers in Europe. It's on a scale that is quite hard to get your head around, to be honest. So it shouldn't therefore be a surprise that when we talk about them procuring a new solution, they're actually talking about years just to buy it. So I think as a trust, we're doing the right things around looking at how can we make things better for the next few years. But we need to be careful to make sure we're also thinking about that new platform coming along one day and haven't accidentally locked ourselves into something that would hold us back in the future. So that's probably something we'll need to come back to in future workforce strategy discussions.
Thank you. That's really helpful. Okay, so that's the statutory and mandatory. The stress-related absence. I don't know who wants to tackle that. Paul, do you want to come in on that initially, please?
Yes, thanks, Mary. It's been a feature that the stats have been higher since the COVID pandemic, and I think what we're seeing is the tail end of some of the additional stress that staff felt going through that and coming back out into what was still obviously then very busy and continues to be a very busy time. I think there's a couple of things. One is we know we can correlate stress to operational pressure, and we can also correlate it to where we've got vacancies, where we've got pressure on the wards and in other places. I think there's something about ongoing resilience, and we are investing in health and well-being, and talking to Alison and CFT colleagues as well, looking at how we can cross-cover both organisations, because there are obviously similarities that are presenting themselves. I think also when we talked about triangling back to some of the training, induction, management guidance, prevention that we're bringing in, it's about being able to recognise both the symptoms of stress in yourself and others, and also having tools to deal with that, and then getting rapid support from us. So we've got a variety of interventions underway. What we want to do, though, is mainstream those into a more cohesive offer for staff, and that's some of the work that Bernie George has done in her occupational health review, looking at the needs and the future needs of health and wellbeing for our workforce. That's something that's actively underway at the moment. We've had some successful interventions that we need to replicate, I think, and build on. And we were talking to staff, and particularly when we come to staff survey in a minute, there's quite a bit of feedback in there around health and wellbeing, and some of the benefits of working in a team come through there. But there's also what we can do for staff and what staff can also do for themselves. So I think it is an area that continues to concern us, and I'm really pleased that it's been escalated. We're talking about it today because keeping the focus on it. I think we've got to understand it's probably a long-term solution, and it's the balance between what we can avoid and what comes with the territory that we're in. So again, it goes back to making RCHT a great place to work and doing everything we can to support our staff and therefore our patients through that. So I think it's an emerging issue. It's complicated, multifactorial, and we're trying to provide something generalist for staff, but also there are some hotspot areas that we're looking into as well, that I think will help us in the long term to get to the bottom of it.
Thank you. I might come back to that in a minute. I've got Rob and then Steve.
Thank you, Mary. The stress-related absence is also a flag for us in the Health and Safety Committee. And listening to Paul's response there, and that we have got representation in the Health and Safety Committee, I wonder, Paul, if we should take an action for you and I to get together before the next Health and Safety Committee to see if we can triangulate some of these actions as well. Then we've got a multiple route in to try and address some of this. The health and safety work also supports colleagues with access to the workplace health stress assessment tools as well, which I think if between Paul and I, we might be able to triangulate some of that to try and help move that indicator a bit quicker than we're currently seeing it move.
Thanks, Robin. That's really helpful.
Thanks, Rob. Steve?
Yeah, I'm grateful for that suggestion, Robin. I was kind of reflecting on that as well. Also, Paul, our joint consultative negotiating committee could be a good opportunity to triangulate some of this work. I know they've got a strong interest in steps that we can take as an organisation to improve the environment for staff, and part of that would be in terms of helping us, I think, to reduce stress-related illness. So in addition to the Health and Safety Committee, I think it might be helpful for this to have some further input from our JCNC and any other staff engagement mechanisms, which potentially could then come back to our People and Culture Committee. I think the things that Paul's already touched on, the impact of excessive work demand, particularly from a flow perspective, but not just in that, is important here, as is culture, environment, civility, respect, leadership behaviours, and our staff support services such as occupational health and elsewhere. Potentially, Mary, in discussion with Health and Safety Committee and with JCNC, we could have an overarching summary of the actions already underway and what else we might need to put in place to help to address that. And I think there'll be a whole range of learning as well nationally, given that this is one of the challenges that faces many other parts of the NHS as well, Paul.
Thank you, Steve.
Thank you, Steve. I think that is really helpful. I think the committee wouldn't have escalated to here if they felt they were getting a leverage on it. So I hope, Adam, it does feel helpful that it's come here. And if we pick up on that second set of actions, which, Lindsay, you might helpfully pop in the chat as you did with the last ones, thank you, that would... But that both of those strains went back to the People and Culture Committee, and then if that was still not feeling sufficient assurance, then it should come back to board again.
No, that's really helpful, Mary, and that was a really helpful conversation that we've just had, and there's some extra suggestions, input that we can bring back to People and Culture Committee. That would be really helpful. Thank you.
Okay, thank you very much. Anything else on Adam's report? In which case, if we could ask you, Paul, to come and present the staff survey results at 15:01, and if we could welcome Christian Francis, People Engagement Lead, who's joining us for this item. So over to you, Paul.
Thank you, Marion. And apologies again, my camera's not working, so unfortunately you can't see me, but I'm joined by Chris, who is led on this, and I'm pleased to say we've bringing here the report on the outcome from the 2023 National Staff Survey. It's a staff survey undertaken by the whole NHS every year. Each trust participates and the same questions are asked. It's totally anonymous, and we have an external company that takes the data and feeds it back to us. So Chris has the amazing job of correlating all that together, and then with the team triangulating that into a lot of the subjects that we've talked about in terms of the workforce. So without more ado, Chris is going to take us through a presentation that takes you through the outcome from the 2023 National Staff Survey, the organisational priorities that we've worked on with management and staff from that, and then the action planning process that's underway at the moment. So hopefully you're there, Chris. Over to you.
Hello, I am. Can you hear me?
I can hear you. Thank you.
Real perfect. So yeah, just thank you very much for having me along to board today. Really appreciate the opportunity to come and present to you. So Pete, can we have the next slide? So just some real top lines from the staff survey, and I think just before we get into those, when we're looking, there is a lot of information, and as you'll have seen in the full benchmark report, there's a lot of information. So we will be talking quite high level today, but what we're comparing ourselves to when we say comparators, there's about 124 similar organisations to us, and that's our comparator group. They're similar acute and acute community trusts like ourselves that benchmark in that group. So a good group of people to compare ourselves, a good group of trusts to compare ourselves to. So some headlines for us, for RCHT, as we go along, is some significant improvements when we compare ourselves to 2022, and that's a really, really positive picture to see some uptake. That is also seen, there's some good improvements nationally too. However, our improvements are pretty significant. When we look at our response rate climbed by 2% on last year, and is 3% ahead of that comparator group I was just outlining initially. Which means a real total of about 3,500 total responses, which is about our second highest ever number of responses. So that means more people than we have had in the past are taking part in the staff survey, which really means more people are having their voice heard, and we're getting a better and more accurate picture of what is happening around the organisation for our colleagues. One of the areas where we are most improved is when we look at the national picture. We're actually in one of the metrics we'll come on to in a second. We're the third most improved organisation in England for I would recommend our organisation as a place to work. So that's a huge change in sentiment, or a huge improvement in sentiment compared to where we were in 2022. A couple of the areas we score better in our people promise areas, which is how we break down the staff survey results into the buckets of questions. And we're the same in one area and below the comparator average in a couple others. For the 2023 results, we are safe and healthy. It's important to note they've not been reported due to a national issue with data. However, that will be being mopped up later on and reported out more widely. Next slide, Pete. Thank you. This is that demonstration of that significant improvement since 2022. So what's happened here is there's a statistical test run on the difference between the results we see in 2022 and 2023 in normalised scores for the people promise. And all of those come out as significantly higher, except the unreported we are safe and healthy, which I've just mentioned. So some really significant improvements there. Thank you, Pete. And then when we look more at how we compare to our peers, this table is quite the overall nice overarching picture. So what we've got is the dark blue bar is ourselves as RCHT. The light blue bar is that comparator group. The orange line is the lowest scoring organisation in that group, and the green line is the highest scoring organisation in that group. And what this shows me is we're in the mix of where our peers are. However, there are areas of improvement that we could certainly make, and that's what we're doing with the action planning process and making sure we listen to staff on how we make those improvements. It's not where we want to be. We're wanting to achieve outstanding care for one and all, so we need to have outstanding staff experience too, and that's where we'll be heading towards with our action planning. Thank you, Pete. And when we look at some of the key questions, a couple of key questions we should pull out from the staff survey, I would recommend the organisation as a place to work. So you can see a significant uptick from 2022 to 2023 in that one, and that correlates through to being the third most improved trust in England for that particular metric. And also, if a friend or relative needed treatment, I would be happy with standard of care, a significant uptick there. One thing just to notice over the past 5 years of data, I suppose, is our reluctance to advocate for ourselves in Cornwall, or at least in RCHT, if we speak for RCHT. We've always trended below the average, but we're heading in a better direction now. And we've narrowed the gap to the best results we've ever seen again this year, although not as high. Thank you, Pete. Next question, next slide. When we look at our top 5 most improved areas, you see those two metrics that we've just covered in terms of recommending the place as a place to work and receiving treatment. but staff felt that they feel there's more staff in the organisation to do their jobs properly, although not a high percentage. Nearly a 9% increase in staff reporting positively on that metric. Levels of pay, again, not a high percentage, but an 8% increase in people feeling happy with their pay. Noting that there was the pay award of last year, which would have come out before the staff survey as well, impacting that question, I should imagine. And then people having adequate materials and supplies. I would have put in the lowest, our biggest decreases. However, any decreases we did see were under in the specific question level data were less than 1%, so staying the same. So there's nothing really that I would flag to board as saying has massively decreased. There really has been a positive, overriding positive change from 2022 to 2023. Thank you, Pete. Just wanted to flag some of the EDI questions, and next slide again, please. So EDI, equality, diversity and inclusion. And what you can see here is maybe a bit cluttered, a bit messy, so apologies for that one. But when we look at our comparators, we score comparatively well in our inclusion metrics, as well as a couple of our diversity and equality metrics there as well. So that is quite a positive picture, and there are a couple that there that we need to focus on and look at, but there is a big EDI agenda going on at the moment to focus on that range of questions. Thank you, Pete. When we look at what is contained within the larger benchmark report, you will see the workforce race equality standard and the workforce disability equality standard in there as well. So a lot of information to include, but those are really important things that the staff survey capture, and something that I thought I would highlight is where it can be found within that report. So they will be being used by the EDI team to report back through the usual channels. And next slide, please, Pete. Finally, when we come to what this all means, so I've thrown up a load of questions in front of everyone and said how well we're doing. But when we have a look at where we want to put our focus on this year, we looked around our compassionate culture. We looked about how we raise concerns in the organisation, and we're also looking at our appraisal processes so to make sure that people are supported and developed as possible. These are the areas where we've scored not as high as our peers, but also areas that we want to, specifically with raising concerns, which has improved, to continue that trajectory, because that's how we have safe staff and safe patients as well. Thank you, Pete. So what's next, or what's going on currently? So the way we've broken down the staff survey action plan, as detailed in the paper process, we've asked our care groups to hold big conversations around the trust priorities and their 3 local priorities, so that we can understand, get a better understanding of what it is that we want to see happen at a corporate level, and also what it means for my data in our care groups, for our own care groups. Alongside this, teams have been receiving their local results, and they're able to action plan with a range of support from managers' guides through to templates, etc., that we provide for them to help them score what's the 1 or 2 things you want to do better within your team. And then bank engagement. The bank staff survey is something that was mandatory from this year. We participated in the previous year. However, the full national results have not been released yet. So we'll be holding our engagement sessions with our bank colleagues with some nice dedicated resource from our Kernoflex team to support that work. And we'll be holding those conversations as soon as the national bank data is released. It's a separate survey for bank-only colleagues that only have a bank contract there as well. So that's what's happening in the background, making sure we're using this information to improve what it feels like to work and receive care at RCHT. Thank you very much.
Thank you, Chris. Sorry, Mary.
I just wanted to know if you wanted to come back in.
I did. Thank you. Just to say thank you very much, Chris, for that. I appreciate the work that you and the team have done for that. And I was going to offer to open the floor to any questions.
Thanks. Ella.
Yeah, thank you, Chris, for that presentation. It's really helpful and informative, and it is really good to see the positive progress that's being made. I think it's really kind of encouraging and notable around the us becoming third in the country third best improvement for people recommending us as a place to work, and we very clearly pulled that out last year as an area of focus and prioritisation for us. So I just want to kind of use that to really endorse the approach of continuing to have a more narrow and specific focus in terms of priorities, because the staff survey questions are wide ranging and huge, and you can't, it's that saying, isn't it, you can't eat the whole elephant in one go. So I welcome the fact you've pulled out 3 areas of priority for substantive staff, and I think 2 for bank. I suppose I'm just challenging us a little bit about whether that's still too many and whether we ought to be more specific. And I'd also like to see, because we've in our strategic priorities continued to say that that is a key metric for us, so people recommending us as a place to work is still a key metric. So whatever priorities we make, we would want to see them, I think, flow through to positively impacting on that metric again, and keep that continuity. And then one final question for you is really around risk, and I think I'm right in saying the people promise kind of support and infrastructure that we were part of as a pilot is now stepping down or step back from, because it was a temporary thing. I just wondered if there's any risk there and what we might need to do to shore up our ability to keep this momentum and keep the progress going.
Thank you, Ella. Paul, just in terms of time, I think I'll collect up the questions and comments and then come back to you if that's all right. So Ian, you're next.
Yeah, thank you. Thank you, Chris, for the work on the paper. I just wanted to call out on page 313 of our pack, it's got the care group response rates versus previous year, and I think it's just worth us acknowledging the great work that surgery, surgical services and clinical support have done in getting 57 and 56% respectively. Previously, I think corporate areas have been the ones, and they're probably ones that have got the most time to sit at a computer and fill out the survey in reality. So I think the promotion that those 2 care groups has done should be acknowledged by us. And I think it just kind of segues quite nicely from the earlier agenda items before lunch, doesn't it, in terms of the priorities. I think I said when we talked about the headlines from the staff survey, this isn't everybody's reality, and whilst it's really good progress, and we should stop and acknowledge that, we should also acknowledge that there'll be people in our organisation, and we've seen that in some of the early reports, who report bullying and harassment, which is not something we should tolerate. So I think the focused priorities on the appraisals that Isabel talked about earlier, and about the speaking up aspects is something I really welcome in terms of our focus.
Thank you, Ian. Aled.
Thank you, Mary. Just briefly, really good. I mean, we had a really good discussion of this in people and culture as well. I think it's just there's slide 13, which was what is next. I think there's a bit of space, and you may already be doing this, which is almost a slide on what just happened, which is what is the causality, even though that's tenuous, that we think that's driving some of these results. I think people are talking about that, but it'd be good maybe in people and culture if we had a bit of a logic model that we think it might be X, Y, and Z driving particular outcomes, just to kind of have a sense of, as well as the forward looking, which is absolutely right, and priority setting and what is next. Yeah, just like what do we think actually happened just then, to see if we can mirror the kind of the success ingredients again and see if that has some sustainability and continuity. Thank you.
Thank you. If I just take Isabella and then come back to, then I'll come back to Paul and come to you.
Thank you. I'll be very brief. First of all, I'd like to congratulate the People Promise team, because I think they've done an amazing job, and I hope that we're retaining their skills within the organisation. So that's the first thing. The second thing is really just in relation to the pressures facing the organisation. I think we've got also a golden opportunity that every time we see improvement in our outcomes, that is going to impact our staff survey, because our staff are also residents in Cornwall. So, you know, they have skin in the game, so to speak. So, you know, the more we can do to improve our operational outcomes, the more likely we are to see those results improve even further. But I would like to say thank you to everybody for all the work that's gone into this.
Thank you, Isabel. Paul, can you pick up those points?
Thank you, Chair. So agree with the points that made. I think Ella's point around maintaining a focus on strategy is absolutely critical, and we all play to our strengths with this. And I think the staff survey is a line of sight, some of the areas that we need to focus on. I think in terms of the People Promise, yes, we were one of the best performers on the People Promise nationally, I'm pleased to say, and it did give us a great start and is the forerunner of our Now OD programme. So pleased to say that the members of the team that worked on People Promise have been retained, and the priorities that we've taken and the learning from the People Promise, we are now feeding into the mainstreaming our OD programme. And also the People Promise cohort 2, which they're the current funded trusts, are looking to us actually to help them, guide them. So I think we've really improved a lot and learned a lot from being part of that. And just wanted to make the link back to Isabel's earlier comment, appraisal being one of our focuses. And Chris, you might not have been in that session, but the focus on improving appraisal, I think that's something we can take from what's come back from the staff survey, making sure they happen. I think I also heard the care group uptake from Ian. I think I just want to say thank you. We had such a great response from the care groups, and Chris may want to add to that they were really positively engaged in this in a way that was really fantastic, because it is a partnership. It's not something we can just do on our own, and we do need staff to fill in the survey so we can hear from them. And then I heard something about causality, and I think that is something we need to, you can make, and we are doing correlation between some of the staff survey, both good and bad, and where that appears in other areas of our people experience. So really appreciate the comments that are made. I don't know if you want to add anything, Chris, or emphasise anything I've said or not.
Yeah, thank you. Again, touching on that point around the care groups, it's absolutely impossible to do anything without the care group support, and they're fully behind the staff survey, as is everyone in all the corporate areas as well. So massive thank you from myself there. It makes my life so much easier. So thank you very much. And in terms of causality, I think I could be wrong. I'm happy to be wrong. But in terms of where the causality will come from, or understanding causality, will probably be within the conversations that we have within the care groups, of saying to I can speculate from my side. I know like the pay increase will probably, the big ticket items will influence, but I will happily bring back some of that causality from our care group and our corporate conversations. And when we ask our staff, what is it that made a difference for you this year? What should we do more of? What should we do less of? What should we start new? So I hope to bring some more of that back within the action planning itself.
Thank you very much, Chris. Richard, and then Kim, and then I think we'll have to move on.
Thank you, and thank you for the paper, and thank you particularly for the slides. It's been really helpful. I guess my questions really are when we will, as a board, get to see that more sophisticated analysis of the staff survey results. There's some headlines here. There's some headlines picked out here which are really helpful and show a direction of travel. But I was also struck by some of the graphs in the paper that suggest 1 in 10 of our staff, or almost 1 in 10 of our staff, have been subject to unwanted behaviour of a sexual nature from clients, and nearly 1 in 20 from fellow colleagues in the staff group. So that there's a few things that hang that might need some specific activity attached to it. I think the other thing is how this forms part of a dynamic conversation, because I'm aware that the survey will have been filled in. I'm not exactly sure the timescale in 2023, but we will now sit in May's board looking at preliminary survey results. By the time we ratify that through an engagement process of what it feels to work like here, we're some way on from where the survey was started. There's no way around that. But I guess it's about how this is part of a more dynamic conversation rather than clusters of activity. And then the third thing, which is really pedantic of me, but it's just a little bugbear, can we differentiate between percentage increase and percentage point increases? Because they're quite different in how we would interpret our results. Thank you.
Thank you. If I take Kim, Paul, and then come back to you. Kim.
Thanks.
Yeah, it follows quite nicely on from Richard and what Ella said earlier. So we've got all this. We've got about 5 months to make an impact before we collect again. So, you know, what are the 3 key things probably we're going to concentrate on and be able to step change or staff in 5 months, and I can't believe we're in May. Before we happen, it will be going back round. So do we need to just be a little bit more tailored in what we're going to do? We have started and we're looking, because the staff survey absolutely collates with what we know in other areas, such as freedom to speak up, complaints, incidences, appraisal, and now the work we're seeing as we have launched the Sexual Safety Charter safeguarding, and for some of our senior staff, those that are in difficulty or having challenging issues to deal with. So we are going to look at a way collectively, Christian, and we'll be in touch to see what is that telling us, and where do we start to see those hotspots, because some of the, if sometimes you look at things on paper, and some of the highest performing care groups have some of the most challenging issues, or freedom to speak up, for example. So how do you not lose that thread, or are we at risk of disaggregating the data so much we miss the point?
Thank you, Kim. And I think thank you for making the point about the Sexual Safety Charter, because there was really, really good attendance at the meeting to launch that in our safeguarding community meeting. And yet, as Richard's pointed out, the figures are worrying, actually. And so for me, there's something, as has been said, about which are the 2 or 3 things that really are totally unacceptable. Racial discrimination, sexual bad behaviour, whatever we want to pick on. And then let's focus on those. And I think it probably has been said at committee, so forgive me, Adam, but I just feel there's... we almost don't need to wait for another staff survey. We shouldn't need to wait for another staff survey, because we know what the issues are. So I don't know, Adam, whether your committee could perhaps take that forward as a, what should we do about this without waiting any longer? Maybe. But Paul, sorry, back to you for the last word on this. We are a bit pushed for time at the moment.
Thank you, Mary. So totally accept the points raised. I think I'd say the staff survey is part of the engagement plan, and it's part of the OD approach. It's not a standalone, although it is the only national survey that happens in the NHS, therefore guides some of our statutory reporting. It is part of that. And you're right, we're not just waiting. It's going to be it's streamlined into our overall engagement and OD plan. I think what it does do, it highlights where we are against our comparators, and it also highlights there's a rich information in terms of where issues are being raised. And I think what the work that Kristen and the team are doing is to actually be tackling some of the bigger issues. I think I take that point around the 3 key areas, but also some bespoke support for care groups and staff groups where they are, so that we can alter and improve people's experience at work. And that's the whole point of the feedback loop with the staff survey, and we want to see that improvement drive through each year now. So I think there's been a slightly different approach. I might bring Chris in just to say on that very briefly, in terms of we are really honing in on some of those issues rather than just action planning it, which is probably where we've been a couple of years ago, and building it into a longer term civility and respect, all the things we talked about today, the OD plan to maintain and sustain a cultural improvement. Chris, did you want to add anything to that?
I think it's thank you. It's not a surprise. Like, we're getting to a bit more of a maturity in the work that we're doing, where we're actually able to use the staff survey to inform our organisational development plan. So that's really, really good, and that's why we're seeing some of the things start to align, so we can see some real progress. So the action planning will complement the work that's going on in terms of the OD activity as well. Just to reassure or assure people that the more detailed information on those where this stuff is happening and where some of the poor behaviours are being seen has been sent out, distributed to care groups as well as exec colleagues as well. So and there's a little bit more in the appendices. There's the full benchmark report if you want to have a look at that at an organisation level, and there's also a breakdown report which shows you how our care groups are performing against the people promise as well, against the organisation. So there's much, we can be here all day, but I won't bore you any longer. Thank you for your time.
Well, thank you, Chris, for what you're doing, and for what it's worth, and I'll repeat it. this is the business of all of us. This is the business of managers, and it's the business of every member of staff. It's not the business of HR in the sense that you're presenting the report, but the responsibility for ensuring the behaviour changes lies with our teams and our managers. So I was very pleased to see in the report the point about the information being passed back to the care groups, because that is where this change will take place. So can I thank you very much for items 15 and 15.1 and ask board please to note the national benchmark major findings from the staff survey, and note the indicative priority areas, and note the approach to action planning across the organisation. And if we could be doing that while I move on, Adam, oh no, it's not you, sorry Isabel, if I move on to Isabel on the Remunerations and Appointments Committee.
Thank you very much. I think we might be able to claw a couple of minutes back because this will be very quick. The paper is pretty self-explanatory. The purpose of the report really is to reflect those discussions and decisions taken by the Remuneration Committee, and you'll see on the front page of the report the key agenda items and the decisions that were made. So I think in the interest of time, I probably won't say anything further.
Absolutely marvellous, thank you very much. And I think for the for members of public and staff watching to be clear that the Remuneration Appointments Committee does consider the very senior managers, and therefore is a more confidential committee than perhaps some of the others are. And so it should be, because it's considering matters to do with individuals and staff. So thank you for your report. Anybody want to ask any further? Great, in which case, please could we note that report and then come to our corporate trustee roles, which I've got somewhere in front of me, here we are. And that brings us to charitable funds. And I think, Andy, you're kindly going to present the report that was actually Sarah Newton's report, but you're going to stand in and present this report. Could I perhaps, before you start, note for everybody's benefit that in considering this and the second part of item 17, we are acting as a corporate trustee to the charity, as opposed to simply board members. Thanks, Andy.
Thank you. Yes, so I'm stepping into the chair role of the Charitable Funds Committee, and our next meeting is next week. Our last meeting was in March when my predecessor, non-exec Sarah Newton, was the chair. Thanks for all of the individuals who have brought me up to speed. I've had quite a number of meetings with individuals who have very much got me up to speed. You've got the report here. I'll just highlight 2 or 3 things which I've learnt and have come out to me. Firstly is the family appeal public launch has been delayed, I believe, till the autumn, and we'll be having a discussion next week on the costs of the project. So until, I mean, Ian is very much on that, so we'll be discussing that next week. The support costs of the charitable funds, there was a review of the costs of running the charities, and it was notable that we're below the median nationally in the costs of running the charity. The other thing that to note is that there's quite a healthy level of charitable funds already raised, and a workshop is being planned for the fund managers in order to give them the assistance to come up with plans to spend the funds. One can speculate as to why it's difficult sometimes to spend the funds, maybe operational pressures and everybody's working very hard, but I think it's very good that we'll be having a workshop to assist those individuals. And then the final thing is what we discussed at the board in April, the appointment of external auditors for the charitable funds in line with good governance. And I think we agreed in April with the recommendation from the committee.
Thank you, Andy. Are there questions for Andy? I guess I only have one, Andy. I'll come to you in a minute, Ian. We are just below the median for our expenditure, or for what it costs us to run. Is that a good thing or a bad thing?
Exactly.
You know, so we're hearing that we're not actually maybe doing what we could be doing, and also I think that question relates to the delay of the next project.
Family appeal, yes. I mean, there will be considerable expenditure in running the family appeal.
Okay, and if I had a £5 note for every time I've sat in a charitable funds workshop working out how to spend the money, I would be doing well. So that I'm saying that not to be rude, but to say that this seems to be difficult. And so I wonder whether we can learn from others as to how they do it. I don't know, but as long as I've been on this board, it has been difficult. And I know that the Friends also find it quite difficult to get some of the funds spent. And yet we're really good at getting very close to budget on our capital expenditure. So how could we learn across, Ian?
Yeah, absolutely. Welcome that challenge and recognise it as a challenge as well. I think it's probably fair to say. So we had the exact conversation around is being below the median a good place to be or not? But it was particularly looking at some of the kind of infrastructure costs to run the charity. So in that sense, but also from a fundraising perspective, we have an agreed ratio of how much income per pound of fundraising costs we look to generate, and that's something that the committee tracks quite closely. Definitely in terms of learning from others, I've personally found actually just going out and visiting the departments and speaking to them and helping them understand and creating that time has been really useful. So yeah, happy to take that back, and we've got, as Andy said, we've got a meeting next week of the committee so we can feed that in.
Thank you. Are there other questions? I think there's a great deal of knowledge in this country about how to run charitable organisations, and there's a lot of professional people doing it. And I guess I just wonder whether, building on what you're saying, Ian, whether we try to find ways of either borrowing or even paying for some of their expertise. But sorry, you can hear I'm passionate about this because it is frustrating that we do well really with our fundraising. And I think I would want to be assured, and perhaps it can come up at the next committee, that there is nothing that we are doing that's preventing us, so our policies as to where the money can be spent and so on, perhaps checking that would be helpful.
Some of the funds are very much earmarked for precise areas rather than being general funds. And so where there are very healthy reserves, those funds can't be spent on general things. So that's one of the difficulties I've learnt in my brief time.
So I'll bring you in, Ella, but that's really what I'm alluding to. Can we be sure that there is nothing that, as trustees, we're doing to prevent us from getting the spend? And I'd be grateful to hear back about that at the next report back. Ella, sorry, I've spoken over you there.
Yeah, you've partially covered it actually, because my experience of running funds in other NHS organisations or in charities linked to NHS organisations is exactly that if you have too specific a purpose, it can be limiting, and that can also be limiting in terms of getting donations as well. So it might be something just around the strategy of how we set up our funds. And I think the workshop with fund managers is a really, really good idea. And then I wondered if we could share from them kind of with the wider senior leadership as well, the outcomes of that workshop and what they think, because it might just be a case of getting more heads around that table and suggesting ways, because this fund manager will have one view in terms of the bit of the organisation they run and what the needs are, but there may be that other colleagues could contribute a different view as well. So I just suppose I'd ask that we share widely what the funds are available for, and seek wider input to that.
Well, that's really helpful. Steve?
Yeah, I think building on that, Ella, I just wonder if there's something we can be doing as we engage with our care groups and specialties across the organisation on the longer term strategic plan about what would their non-NHS funded developments and opportunities be. So notwithstanding the role of the Charitable Funds Committee, but actually can we embed some of this into how we work on a regular basis? And is there something that is kind of aligned with our strategic planning and or our business planning each year to say what would the priorities be for renal services, paediatrics, colorectal surgery, etc., that if charitable funding was to be available, what would your top 3 priorities be for added value? And that might then help that process as well.
Thank you, Steve. Really, really helpful. Sorry, we probably spent longer on that than we should, but wasn't it?
I'll make it very short. Just on your point, Steve, I wonder, doing that exercise, whether that would also help staff overall trust engagement, because I noticed when I observed the charity committee, our social media followers for the charity profiles are tiny. I mean, it's in the hundreds, not even the thousands, and obviously even if all of our staff were following what we're doing, let alone, patients and other people. So I wonder whether that exercise could just overall help everyone get on board to think this is for all of us. It benefits us all. Let's all think of how we can contribute to how to spend it, how to raise it. So I think there is a piece there on how we can engage the trust.
Thank you. Okay, so if we then move on to 17.1, and then we'll come back to noting both items here. Ian.
Yeah, thank you. So this paper has been broached at the request of the board in terms of understanding a bit more around the management of the investment portfolio. So I'll take the paper as read and just pull out a few elements. So that it's important to say that the charity has an investments policy that's reviewed annually. It was last reviewed in September 23. And in terms of concept of value, at the end of March 24, the charity held around £2 million in its investment portfolio. There's two funds that the investments are held in. One's called the discretionary investment portfolio, which is where the majority of our funds are. And a few years ago, we opened a different fund, which is the advisory investment impact fund, which is an ethical only fund. So is a more ethical fund to invest our money in. You see in the report the combined performance of the two funds. The ethical one does underperform against the main fund, and essentially that was the Charitable Funds Committee testing that with initially a £250,000 investment into that fund when we originally put it in there. The key purpose of the investment fund and having Barclays Wealth as the investment manager is to make sure that we keep the value of the funds that we've got whilst they're not being spent, to make sure that they're spent, one, in line with the donors' wishes, whether that be fundraising, legacies, grants, etc., and to demonstrate that we've got effective processes for managing that funding. I talked about the ethical nature of the impact fund. It's worth making clear, though, that the main fund does have a number of restrictions against it. So the report calls those out, but tobacco, arms, gambling, pornography, and last year the committee reviewed that and added alcohol because of its detrimental impacts on health, and as a health organisation, we felt that was an appropriate additional exclusion to add. So, but it doesn't go as far as, for example, not allowing investments in big companies that might have fossil fuel related and that sort of things. That conversation happens regularly. We've got the review of investments at the next Charitable Funds Committee next week, and would welcome any feedback from the board in terms of any elements that it'd be useful to feed into that conversation. And then just finally, to the investment performance of Barclays Wealth Management, who's our current incumbent investment portfolio advisors, is again scrutinised by the committee annually, and that includes benchmarks against other investment portfolio companies to ensure that we are getting a good quality of service and a level of return. So hopefully the paper gives a bit of context. There's probably a lot more detail underneath that we do in the Charitable Funds Committee, but hopefully that gives a flavour.
Yes, it does. Thank you. And I know a lot of work has gone into all of the aspects that you highlight in the paper. Are there questions? There is one. I can't see it. Adam.
Thank you, Mary. Thank you, Ian. You've specifically mentioned the paragraph I was going to ask you about, which is paragraph 3.4, which talks about the constraints on who we're comfortable to invest our charitable funds with. I completely recognise the challenge between return and where we choose to put our money, but I suppose I'm questioning whether the limitation we put in paragraph 3.4 is sufficient, particularly in the context perhaps of a meeting where we've talked about the green plan and the climate challenge, and how does that current restriction benchmark against other NHS charitable funds might be worth exploring if we haven't already.
Thank you, Adam. Perhaps that's something we could pass on to the committee to look into.
Yep, absolutely.
Great, thank you. In which case, could we look at items 17 and 17.1 and note the report and note the work and the investment managers? And we will please move on to item 18, which is from Adam, the Audit and Risk Assurance Committee Assurance Report. Adam, please.
Thank you, Mary. I just need to get to the right page. So page 333 in our pack is the start of the Audit and Risk Assurance Committee Assurance Report to the board, reporting on our March meeting, which was a very thorough meeting. I'm going to assume people have read the report. I'm just going to highlight a couple of critical points. First up, credit to our counter-fraud specialist who received a national award. Congratulations to him for that. To emphasise, we have clear internal and external audit plans in place for 2024-25 based on the risks the organisation are facing, and obviously that's so important to have that independent challenge and review, and that's in place for 24-25. To highlight, we weren't able to have a full discussion on the corporate risk register as not all the papers were available at the time of the Audit and Risk Committee, but they are on our agenda today as a following item. So we're able to do that here if we so wish. And then to flag the two items that we brought from Audit Committee for board's attention, which very much chime with what we've discussed in this meeting today. The lack of a system assurance framework around risk for the whole health system in Cornwall. That's being worked on across the system, but it doesn't exist as at today, and that's worth bringing to the board's attention. And then an item which we've discussed a lot today was we actually, in the internal audit plan for 23-24, we asked internal audit to look at our freedom to speak up process. We asked them to do that every 3 years, and that was this year that's just finished. They produced their independent review of that, and they flagged they felt it was important for one of our committees to look in more detail at freedom to speak up. So we have referred that to the People and Culture Committee, which obviously I chair as well, and we're going to reflect that in our culture discussion that we have at People and Culture Committee twice a year. And I'll stop there, Chair. Happy to take any questions.
Thank you, Adam. Colleagues, questions for Adam? Okay, Adam, do you think that our next couple of items will sufficiently cover that which you wanted to have covered? I know it won't with the system risk register.
I see what you mean. We just wanted to raise those items for the board's attention. I don't think we need to have any further discussion about them at this point. We've had a really good discussion about freedom to speak up and the system assurance framework, recognising that's a work in progress with colleagues across the system.
Thank you very much for that. In which case, if there are no further questions, we will note the item and move on to the 18.1, which is the Board Assurance Framework Report. Lindsay.
Thank you, Chair. So presented is the Board Assurance Framework. Updates to each of the BAF elements are made by through the committee and with our executive leads. These are reported in the pack, and for ease, there are track changes for transparency, and the changes are summarised in the report. Also, the board last approved the BAF in March 24. Just to highlight a couple of things for each of the BAF elements. BAF 1, relating to care, we've had a number of meetings stood down with our executive lead. However, we had good discussion at the committee meetings. We've reaffirmed our commitment with the execs around making sure that these meetings take place as a priority. BAF 2, regarding workforce, people will see when the recommendations there is a proposal to close two actions which relate to the People Promise funding, which came to an end in March of this year, and we're moving those actions into a business as usual process, which links in with the OD plan. BAF 3 relating to integrated health services. We had a really good discussion. We've updated the BAF element Steve mentioned earlier on around the terms of reference for the Joint Service Improvement and Quality Committee being approved, obviously, which is very positive. And Adam has just mentioned then around the work we're doing around a system assurance framework, which will be integral to that committee as well. BAF 4, which relates to the financial recovery, we have submitted our operational financial plan today, which is very positive, and we've committed to review that this BAF element in relation to that. Also, there's a recommendation in the report that we are to close action 4, which relates to industrial action, which has been mitigated. Two more quickly, if that's okay, Chair. With regard to BAF 5 and digital, we took some further assurance at our last discussion with the executive lead around the E3 maternity services, noting that this was a nationwide issue. However, we determined that we would retain it on the BAF and then consider that on a regular basis. There is further recommendation to close M1B, which relates to the Cybersecurity Operations Centre, which is now operational, noting that there's an additional action included, which will be the monitoring of that going forward. Lastly, with regards to BAF 6, which is to do with our estates, we really welcomed Brian Johnson, our new Director of Estates and Facilities, recently, and we had a really comprehensive review, noting that the 6 facet survey is due to conclude and report fairly soon, which will have really impact on our current risks. So that's all I was going to say, Chair, if that's okay.
Thank you very much. Colleagues, are there comments or questions? Adam.
Thank you, Lindsay. It's possibly a question just to confirm my understanding, please, for Ian more than Lindsay. The item that we're asked to approve for closure on BAF 4, so I'm looking at page 347 of our pack, proposed closure of action 4 relating to industrial action. I think that relates to 23-24 financial year, and based on what we've talked about in this meeting earlier, we'll have to reopen it again for 24-25 in the event there is any industrial action in 24-25.
Yeah, so you're absolutely right, Adam. So that was specifically in terms of the additional costs we'd incurred and the funding that we were waiting to receive. That's subsequently been confirmed at the end of last financial year. But you're right, should we have further industrial action and costs incurred from that, we would obviously reopen that as part of reviewing this BAF every month as we go into 24-25. Thank you.
Thank you, Ian. I'm just wondering whether, therefore, we should keep it open, given that there is still room for the junior doctors to strike up until the autumn, isn't there, in terms of the mandate they've got?
Our preference would be to flag it in the risk section because it remains a risk. The specific action was around confirming funding. So I think if people are comfortable, I would prefer to close it, and I'll make sure with Lindsay we reflect it in the risk at this stage.
Seems very sensible, yeah. Okay, thank you. In that case, we are being asked to note the report, approve the closure of the 4 gaps as Lindsay has outlined. I won't read them all out again. And also to note the arrival of the Director of Estates, who will enable us to make better judgments on that. So if we could please note and approve those closures. We'll come to the risk register. And who's going to present that, Lindsay? It's Aoife here. Sorry, Aoife. Oh, there you are. Yeah. Welcome to the meeting. Thank you for being here.
No worries. Thank you, Chair, and good afternoon, everyone. Nice to see you all. I'm presenting the corporate risk register today. As the board may be aware, the risks get reviewed individually by the responsible executive director and are then presented to our monthly executive risk group. And the corporate risk register is also reported to the Audit and Risk Assurance Committee. Just a couple of points to note. At the time of this report, there were no new risks added to the register or removed from it. And the other point I wanted to note was the Corporate Risk Register report went to the Audit, Risk and Assurance Committee in March, but as Adam states, the appendices, including the detail of each risk, was not presented. And I wanted to note that in the intervening 2 months, things have progressed on the Corporate Risk Register, as you would expect, and this will be evident in the next reporting to the Audit, Risk and Assurance Committee this month, and then onward back to this board.
Thanks very much. Adam, did you want to add anything there?
Thank you, Aoife and Mary. Maybe just to ask a question, or just for the board's benefit, perhaps, for executive colleagues to outline what has been done with the 2 risks that are highlighted in the recommendations briefly, subsequent to the audit committee. So risk 9048 and risk 7459. What is being done to address those risks?
Of course, more than happy to do that. So 9048 is our risk of ED overcrowding in the trust, which is currently scored at a 20. We have had a verbal conversation in terms of that risk at the last 2 exec risk groups, and an update is going to be provided to this month's risk group. I think the board is well cited in terms of the flow programme and all of the work underway in terms of overcrowding in the emergency department. So we'll have an update back to exec risk group, as I say, this month. And then secondly, 7459 is our risk around the maxims incorrect service selection. So this risk was approved by the last exec risk group. Alistair is our executive owner in terms of this risk, and a task and finish group is currently being established to take the actions detailed forward that were presented to the exec risk group this month.
Thank you.
Thank you, Aoife. Are there any other comments? Kelvin.
Just to add on 7459, just to highlight for everybody, Maxims is one of the systems that will be replaced by the EPR.
Thank you. In which case, I think we are then just asked to note those matters, no new risks. There was one risk, sorry, I beg your pardon, there were no risks removed, and that we're noting the current position and the outstanding actions as described, 9048 and 7459. Thank you, Aoife. You're welcome to join us, but you don't have to. Thank you for coming anyway. Appreciate that. Bringing us then to the committee annual reports, evaluation of effectiveness and terms of reference. Lindsay.
Thank you, Chair. Presented is the summary of the outcomes of the committee annual report for 23-24, which demonstrates how they have complied with their terms of reference. The key aspect of the annual report is the review of committee effectiveness, which is completed on an annual basis through a questionnaire which highlights are presented in this in the annual report. There were some common themes across the committees this year. Those included areas where committee members felt that it would be better to have a greater sight on national developments and the impacts on the committee. It was noted that across most of committee meetings there had been an increase in the length of agendas. Meetings were growing in size, which reflected the range of the matters being discussed. The quality of papers was another area that got picked up, and the need to be succinct and drawing out the key things that the committee needs to be aware of. Also, how the committees are appropriately cited on developments within the ICS as well. The committee reviewed and considered the areas for improvement, and these key outcomes will inform ongoing discussions as well as inform the development of the 24-25 governance improvement plan. I need to draw to a board's attention an error in the report, unfortunately, so please accept my apologies. The track changes for the terms of reference for the People and Culture Committee were not included, therefore the version included is not the most current version. The changes were quite minimal. They related to inclusion of clarity of policies that will go through the committee and confirmation of the subcommittee arrangements. It's listed 4 in the pack, but it's actually only 1. So I'm sincerely sorry for the error. Therefore, if it's possible, Chair, I'd be asking the committee to make the approvals as per the covering report, with the exception of People and Culture Committee, where I'd like to suggest that we circulate this after the meeting and ask board members to make a decision regarding e-governance. Just for note as well, that will then get reported back through to the board. But it's really important that we are very open and transparent, and we share our terms of reference on our website, so that they will be published as then when they're approved. So they are available for public consumption.
Thank you, Lindsay. And thank you for doing that piece of work, because that is quite a weighty piece of work. Even if we don't take into account how many times you gently remind us to respond to the survey. And so thank you. And I think that has been, well, I think it's been one of our better years in terms of doing this. I think it's been really good responses. And I think it was interesting where you drew out the themes. I'm sure we can learn from those. And we'll come on to the terms of reference in a minute. Is there any comment on the committee effectiveness?
I was just going to add to the comment about papers being succinct, which I'm completely supportive of, but maybe a refinement to that when it comes to business cases. Most business cases can be succinct, but we do have a couple which are of such significance and also have to fit with nationally mandated templates. They are quite long, but I think we do work quite hard to make sure each section within it is clear and readable, so you can kind of dip in and make sense of it. So it's perhaps just a helpful addition around an absolutely valid comment.
Yeah, and you do work hard to get them to be understandable. So yeah, thank you for that. Richard.
Echo all the comments that you've said there about the value of this piece of work. It's a huge undertaking and it's done really, really well. I think we learn a great deal from the assurance that we get that each committee has undertaken carried out its undertakings to the board, and the narrative that surrounds that. I think we take a great deal from the thematic analysis that comes out of it in terms of how committees are and subcommittees are performing, as well as the board. I do think a comment for perhaps the board to hold on to when we think about this next year as the value of some of the numerical understanding and the numerical analysis for what is categorical data, because we do quite a bit of comparator to previous years, etc. Given that they're different cohorts, it doesn't really help us as much, and looking at mean values for categorical data probably isn't as helpful as just going, people rated that excellent, satisfactory, or whatever. So I think we could cut down a little bit of the work and still get all of the value out of the report next year, but it's a thought to hold on to, perhaps.
Yeah, that's helpful. And the excellent was your committee, I suppose, was it?
Always, yeah, absolutely.
Okay, thanks for that. Are there any other comments? So what we're proposing then is that we accept the, could you say it? It's the People and Culture Committee we want to do by e-governance. So what we're asking is that we approve all of these other than the People and Culture Committee, that we will approve that by e-governance after the meeting, but that it won't impede those terms of reference going on our website. Okay, are people happy to agree that? Super, thank you very much. Then we've got starred item of the biannual report of the use of the trust seal. I always like that, really. I imagine those little grey things that we see in the bay rather than anything else. And so I haven't had anybody raise any matters on that. And then item 21, the consideration of risk. Lindsay.
Thank you, Chair. It's been some really good discussion today, I think, so I really welcome colleagues to help and chip in with their thoughts and comments. Also, I think we talked a lot around our challenging operational environment and delivery of our financial and operational plan, which is reflected on our board assurance framework. We talked a lot about mandatory and statutory training, and as well as our stress-related absences. I think that mandatory and statutory training is reflected within our BAF, but I think we should look at that again and how we can strengthen the mitigating actions that we've agreed to take forward today. And I think we should also then refer to a stress-related absence within that, and in addition. We talked about the cost impact of our capital programme of 24-25. I think that's, again, is reflected within the BAF. We can consider that when we look at the next update on our prioritisation. I think we've talked again around the system assurance framework, and I think board colleagues will have sought some reassurance today that we are still progressing that, but that is something that sits again within our BAF as something that we should progress at pace. And we talked about industrial action, noting that we would add it back into the BAF once we were notified of any further change. Welcome comments from other colleagues.
Anybody picked up anything else in today's meeting? Ian.
I just wonder if we need to reflect the green plan update and the risk around achieving our target by 2030. That feels like probably an important one to capture from today's discussion as well.
Well said, Ian. Thank you. Any other? Okay, thank you, Lindsay. That brings us to item 22, late, for which I apologise. I'm really sorry to any members of the public who were hoping we would get to this in a little more timely manner. Lindsay, are there questions from the public?
Thank you, Chair. We have three questions from Jane Burnell. She's asked if her questions could be, the first two questions could be read together. So Jane says, all my questions concern RCHT patients being treated in hospitals outside of Cornwall. It probably makes sense for the first two to be taken together. So question one, patients on elective waiting lists are encouraged to choose to allow clinicians to refer them to units elsewhere in the country that have spare capacity. What support with accommodation and travel is available for such patients and their families? And what information are they routinely given about exactly how to access this support? I'll then go on to the next question. Is similar support available for NHS patients who have to be referred to units outside of Cornwall because the procedure is not available from RCHT? And I'm going to ask Robin to comment on those first two questions. Thank you.
Thank you, Lindsay. Thank you, Jane. And actually, my answer is to both questions. It's the same response, which is we do offer tailored support to patients if they are to travel out of county. We have a standard letter and a template that allows patients and relatives to fill in a form which can reimburse travel expenses, etc. We also engage in having an individual conversation with patients, and an example of that is in our recent 2 super clinics in orthopaedics. Our ICB colleagues have attended those sessions and have been able to sit with individual patients and discuss the options and support around how we can facilitate patients travelling out of county. It should also be noted that for some of our patient cohort, we do also identify to them what the travel difference is between one of our sites and one of the other sites that we're proposing. If you think particularly orthopaedics in Hale, that's the very west end of the county. There's a significant proportion of our patients are in the east of the county. So in some regards, Jane, those tailored conversations also identify to those patients that one of those other providers is actually less distance for them to travel than our existing sites. And if you'd like, Jane, if you let Lindsay know, we can forward on to you the standard letter and form, etc., that we give to patients as part of their the support package. Thank you.
Rob, that's helpful. I suppose there was a third question, wasn't there? Yes. Okay.
Thank you, Chair. So the third question from Jane is, where NHS patients are treated outside the county, who is responsible at discharge for assessing their fitness to make what is often a long journey, and whether the accommodation to which they are to be discharged is safe? I'm going to go to Robin and Alistair to comment on that.
Thank you.
Yes, so perhaps I can come in first, Robin. So I think there are two ways by which this happens. So first of all, patients can go directly from the GP referral to providers outside the southwest and outside the county. So under those circumstances, patients would be treated at that provider, and discharge from that provider would be the responsibility of the clinical team at that provider to make sure that that was safe for them to go home. We do have instances where we transfer patients from RCHT to an external provider. Some of those patients come back to us as an inpatient, in which case that's our responsibility. But again, if those patients are discharged home directly from a provider outside the county, then it would be, again, the responsibility of the clinicians discharging to make sure that that discharge is safe.
Thank you very much, Alistair. Did you want Robin to comment?
No, that's it. Thank you very much, Chair.
Okay, I think that then concludes the questions for the public. Jane, thank you for your ever present attention and listening in. We value your questions. I do hope some of you have filled in the survey about the meeting. That then brings us to item 23, the effectiveness of our meeting today. And I did give Richard II warning that we would bring him in at this point, but without, he's not the only one. So what we look at is what worked well, what would have been more effective if, have we been consistent with our etiquette? Have we contributed to patient safety? Have we considered the triple aim, health inequalities? And are there matters to communicate to system partners? So, colleagues, I apologise for being a little bit late, but thank you for today. Are there reflections on the meeting? Richard's going to jump in.
You did warn me, so I feel obliged and honoured to give my feedback. I mean, given it's my first meeting, I found a very welcoming meeting, and coming in, the tone is important. I found it very open and non-defensive, so that's a very good first impression. I think it's really important that we devolve to our subcommittees. It gives them, they do the heavy lifting, as you say, but it's also more a better time spent. I think there was the right balance between celebration, sharing good practice and challenge. I think the conversations that are most rich are the ones where we join up themes. So when we were looking at staffing hours, freedom to speak up and the qualification of global staff, we were beginning to make connections between different areas, and I found that very useful. So thank you very much.
Thank you.
My only other observation would be, as charity treasurer for the charity, it was useful to have a bit of the agenda today in terms of the corporate trustee role that the board serves as well, and just to get some of that feedback. I know we didn't spend a long time on it, but actually that feedback would be really useful, and hopefully, I think, really valuable to Andy and myself in terms of the work of that committee. So thank you.
I thought it was valuable that we possibly paid more attention than we have in the past, or that maybe not, to picking up on what's escalated from committees and taking some action as to what we might do with that. I was really pleased that we were running to time before lunch, and then we lost it, didn't we? Aled, and then Isabel, and then
procedurally from the online community, as it were, and apologies I can't be there in person, but yeah, it worked really well in terms of the communications and the clarity, and always felt part of the discussion. So thanks, Mary, for chairing that part of the meeting as well. Thank you.
Aled, Isabel.
Yeah, I think it's been a really good meeting, and I think what's been interesting for me today is the two things. One is that the committees are obviously doing their jobs, so what we're bringing to board, I think, are the right things. And secondly, for me, the level of triangulation that we began to do today across some of the agenda items, which I just think felt really important for the board to actually come together and coalesce around a group of things which are all interrelated. So for me, that felt a really helpful way for the board to understand more about the very complex agenda that we're trying to manage.
Yeah, that's a really helpful comment, Isabel, because I think sometimes as a committee member, you can wonder where it gets joined up, and properly it should get joined up at board. So thank you for that. Alistair.
Yeah, I just wanted to say thank you to Adam again for bringing us back to the fact that we got into financial balance for last year. It feels like we do some amazing things, and we talk about them sometimes as if they're every day, and we just move on to the next thing. But actually, that is a massive milestone for this for Cornwall to be able to do that, and it felt like we might have just strolled past it. And I think there is a tendency for there's always more work for us to do, isn't there? But just to say thank you to Adam for bringing us back to that.
Well said. Well said. Adam and then Richard.
Thank you. These have kind of been said already, but Alid made the point about it worked really well for those of us online, to the point where I wasn't entirely sure who was online, which is a compliment. And then the point I think, Mary, you made about, I thought we took it up a notch in terms of the way we were discussing issues being brought to the board by the committees. So the people and culture discussion I found really helpful, and the way forward on that I think is a real improvement on what we had before. So thank you. I thought that was good.
Much, Adam. Richard.
Yeah, thank you. I mean, I think the meeting's gone very well. I think we've covered a lot of ground in a lot of depth. I was just reflecting on Alistair's comment, because I think it's probably helpful also to reflect to the board that we've achieved those financial targets while still giving good, strong diligence and assurance around our quality. And we're also seeing our quality metrics moving in the right direction. I think as a board, we will never take comfort. But I think as a board, we can take a greater assurance that we're not just chasing a financial break-even position. We're actually doing the right things as a trust and achieving the right quality metrics, and challenging ourselves as to whether that is the case in depth. I think that's important to balance those two as a celebration.
And will be the more so as we go into this even more challenging year. Yeah, thank you, Richard. Yeah, I thought the discussion we had under the Freedom to Speak Up, which I thought was brilliantly placed after the Guardian of Safe Working Hours, was really very painful but very good, because it did demonstrate how far we've come. I remember when I was the Freedom to Speak Up non-exec director, it was really different, and that isn't that many years ago. So though I found it distressing to listen to the recording, I thought it was superb, and I thought it was a really good way to communicate. So I think, having said we mustn't keep celebrating being at first base, I think that gave us an example of moving on, albeit a lot to do. So that was good. Okay, any more? No? In which case, can I thank everybody for being here. The date of our next board meeting held in public is the 4th of July, Independence Day. What should we do with it? And we are now going to take a short break before we move into our board meeting in private. So thank you very much, everybody. Could I propose, or could I request, that maybe we only take 25 minutes or even 20? How do people feel? 20 minutes, so could we come back? This is because Richard II is here, because I said to him yesterday afternoon, no, don't worry, we always finish our meetings on time. so I'm dependent on everybody to help me. So if we could come back at 3:10, that would be very helpful. Thanks a lot. Bye, everybody.